بسم الله الرحمن الرحيم. الحمد لله والصلاة والسلام على رسول الله. السلام عليكم ورحمة الله وبركاته. Welcome everybody. This is Dr. Bender Dawanhuni, consultant endocrinologist. I'm happy today to meet you in the second day of our course about thyroid disorders. My colleague yesterday, Dr. Hamid Al-Sahafi, he started the journey in the first day, and today we'll go for the topics which are available in the schedule in the second day. It's my pleasure to be with all of you. I have to thank you for yesterday attendance. I have to thank for the support from the organizers. Hope the benefit will be for all of you in the second day as well. With no further delay, I will proceed with the first topic. Please, if you have any difficulties or any problem with the presentation or my voice, just type it down in the chat box. So it give me like alarm so I can modify it or correct it with the IT support. So again, if you have any difficulties with my voice or with the presentation, please down in the chat, you can type it. Our first topic today is hyperthyroidism. I know my colleague, Dr. Hamid, yesterday, he gave you some views about Graves' disease, and my term today to talk about the other aspect of the hyperthyroidism, which is toxic nodular goiter. So I will try to focus on the some of the important issues covering this topic. This is a quick we can say icebreaker. I hope it pays your attention to go for the topic. Hyperthyroidism, definition, epidemiology, causes, clinical presentation, laboratory diagnosis, and management are the outlines of our topic. Hyperthyroidism is a hypermetabolic state resulting from excess thyroid hormone. The epidemiology of hyperthyroidism, as you can see here, in some areas around the world, we have severe iodine deficiency, which is seen in the dark green light areas in the map. Moderate iodine deficiency in the lighter green, and in the light green or soft green, mild iodine deficiency. And there are some areas around the world in which we have a little suspicious or suspected cases to be seen with iodine deficiency. I think many rules, for example, availability of the CB has signed, the country, the type of the food, all these items or factors may play a role in the distribution of the iodine deficiency around the world. And we know iodine deficiency play a role in the thyroid diseases. And there are some areas as well. There is an optimal intake of iodine around the world. So this is about the epidemiology in the distribution of the map. The hyperthyroidism is more common in female than in men. It's about 5-to-1 ratio. This is very important fact while you are dealing with your patient. In the clinic, usually thyroid diseases, majority are females, are observed even in the clinical practice, daily clinical practice. The overall prevalence of hyperthyroidism, which is approximately 1.3%, increases to 4 to 5% in older women. Hyperthyroidism is also more common in smoker. Yesterday, Dr. Hamid, he told you about Graves' disease is seen most often in younger female, while toxic nodular goiter is more common in older female. So this is a good comparison. The toxic nodular goiter is more common in the older female. What are the causes? Several different disorders can cause hyperthyroidism. It is essential that correct cause should be identified because appropriate therapy depends upon the underlying mechanism of hyperthyroidism. From the pathogenic viewpoint, hyperthyroidism results from two different mechanisms, which can be distinguished by finding on the 24 radioactive iodine uptake. So it is essential in all cases of hyperthyroidism that you have to go for 24-hour iodine uptake or 24-hour thyroid uptake scanning. What is the benefit? It will give you the diagnosis. Maybe you are dealing with a patient like he has Graves' disease, or the patient with toxic nodule, or patient with toxic multinodular goiter, or even if the patient has thyroiditis. Usually in hyperthyroidism, we have high uptake scanning, but in cases of thyroiditis, we have low uptake scanning. So one of the important issues that you have to keep it in your mind, that thyroid uptake scanning is very essential. Uh, very essential in cases of hyperthyroidism. So some centers maybe they are using technetium, some centers maybe they are using iodine dye. So it depends on the center. Definitely you have to go for the available option to deal with appropriate approach. Hyperthyroidism with a normal or high radioactive iodine uptake. So this is the issue here. The hyperthyroidism with a normal or high radioactive iodine uptake, we have differential diagnosis. The differential diagnosis including the following: autoimmune thyroid disease like Graves' disease, as Dr. Hamid told you yesterday. The second differential diagnosis under this category is Hashi toxicosis. And the number two differential diagnosis we have here is the autonomous thyroid tissue. And the differential diagnosis under this category includes toxic multinodular goiter and toxic adenoma. And the third category here is TSH-mediated hyperthyroidism. And we have two items here: TSH-producing pituitary adenoma, non-neoplastic TSH-mediated hyperthyroidism. And number four, human chorionic gonadotropin-mediated, like hyperemesis gravidarum and trophoblastic disease. So while you are dealing with hyperthyroidism cases, you have to think about all the following in the differential diagnosis, because this category, as I told you, hyperthyroidism with normal or high radioactive iodine uptake. Number two, we have hyperthyroidism with a near absent radioactive iodine. And the hyperthyroidism with a near absent radioactive iodine include either inflammation and destruction of thyroid tissue with release of performed hormone into circulation with an extrathyroidal source of thyroid hormone. So what does it mean here? Here you are dealing, it means with thyroiditis cases, thyroiditis cases. As we know, the problem is already there are some performed thyroid hormones inside thyroid gland, and by the time there is inflammation, it will be released in the circulation. There are no extra or excess thyroid hormone synthesis. So in the thyroiditis issues, we have, as I told you, release of performed hormone into circulation with extrathyroidal source of thyroid hormone. Thyroid hormone is not being actively synthesized when hyperthyroidism is due to thyroid inflammation. As a result, thionamide therapy is not useful in these disorders. The differential diagnosis under this category, low radioactive iodine uptake, including number one, thyroiditis, as I mentioned, and we have many items under this one, including subacute granulomatous thyroiditis, which is called dequivran, and number two, we have a painless thyroiditis, which is called silent thyroiditis or lymphocytic thyroiditis. Number three, we have postpartum thyroiditis. Number four, we have amiodarone, which is one of the drugs used as anti-arrhythmic drug, also may cause iodine-induced hyperthyroidism. Number four, we have radiation thyroiditis. Number five, we have palpation thyroiditis. And the second category here, it is called exogenous thyroid hormone intake. What are the examples? Excessive replacement therapy, intentional suppressive therapy. If, for example, some of the patient using thyroxine to lose the weight, or for obesity, factitious hyperthyroidism also one of the items here in this category. And the next one is the ectopic hyperthyroidism. And we have many items under the ectopic hyperthyroidism, including stroma ovari, which is ovarian tumor, which may produce or have some cells or tissues like thyroid and produce thyroid hormones. And the second item under this category, it is called metastatic follicular thyroid carcinoma. So it's not a simple to deal with hyperthyroidism. I mean, low TSH and high FT4. It's not simple. You have to go for differential diagnosis in all the cases to deal with appropriate diagnosis, and definitely you can go with appropriate treatment accordingly. I hope it is clear. Now is the pictures of the thyroid scan. You see here, this is the normal thyroid scan of the normal thyroid gland. But if the patient has a Graves' disease, we have uptake all over the gland. Increase uptake all over the gland. So if you compare Graves' disease with a normal, uptake is there in all the gland, but it is increased in Graves' disease in the diffuse intake all over the gland. But toxic multinodular goiter, we are seeing multiple nodules. You see here nodules in the right side, nodules in the left side, and by this way, you are seeing multiple nodules which are toxic and hyperthyroid, which synthesize more thyroxine. And the opposite side here, or the last one, toxic nodule, only one nodule in one of the sides of the thyroid gland, and it is, we can say, hyperthyroid, or more increasing the synthesis of the thyroid hormones. Definitely by this case, you will diagnose toxic adenoma. Only single adenoma is high intake, and toxic multinodular high intake, but in both sides. I hope it is clear after this picture of the thyroid uptake scanning. Next issue is the overview of the clinical manifestation of hyperthyroidism in adults. The clinical manifestation of hyperthyroidism are largely independent of its cause. However, the disorder can cause hyperthyroidism may have other effects. And in particular, we know Graves' disease, which is the most common cause, as Dr. Hamid told you yesterday, not related to high serum thyroid hormone, uh, 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 unique problems, I mean, that are not related to high serum thyroid hormones. These include Graves' disease ophthalmopathy, one of the signs available here, and infiltrative dermopathy, localized or peritibial myxedema. So this is again one of the differential, or one of the signs you are seeing. And most patients with Graves' most patients with Graves' hyperthyroidism have a diffuse goiter. And, but so do patient with less common causes of hyperthyroidism, such as painless thyroiditis and thyroglobulin, TSH secreting pituitary tumor. So again, one of the stigmata of Graves' disease is ophthalmopathy. You are seeing signs of hyperthyroidism. What are the other manifestations that can be seen? Skin is warm and maybe rarely be erythematous or red in hyperthyroidism due to increased blood flow. It is also smooth because of a decrease in keratin layer. Other changes including sweating as well, due to increased caloreogenesis that is often associated with heat intolerance. So this is one of the terminology. It is called heat intolerance. Patient feels hot even in cold weather. Hyperpigmentation can occur in severe cases. It appears to be mediated by accelerated cortisol metabolism, leading to increased corticotropin ACTH secretion. So one of the associations that can be seen is the hyperpigmentation, because we know that the autoimmune disorder or autoimmune underlying cause is the same in Graves' disease and adrenal insufficiency, or what is called Addison disease. So one of the manifestations as well is the hyperpigmentation. What about cardiovascular disease or signs or symptoms? Patients with hyperthyroidism have an increase in cardiac output due to both to increase peripheral oxygen need and increase cardiac contractility. So one of the signs as well to be seen here is the increasing in the heart rate, pulse pressure is wide, peripheral vascular resistance is decreased, systolic hypertension is common, the left ventricular ejection fraction does not increase appropriately due to exercise during exercise, suggesting the presence of a true cardiomyopathy. High or normal output congestive heart failure can occur in patients with severe hyperthyroidism, and congestive heart failure worsen in patients with already have it. So these are the symptoms or signs that can be seen in cases or related to cardiovascular disease in cases of hyperthyroidism that may be observed. Next is the atrial fibrillation. What is the atrial fibrillation? We know one of the arrhythmias that can be seen in hyperthyroid cases, atrial fibrillation, which can occur in about 10 to 20% of patients with hyperthyroidism and is more common in elderly patients. In one study, 8% of all patients and 15% of patients between age 70 to 79 developed atrial fibrillation within 30 days of the diagnosis of hyperthyroidism. And the increased incidence of atrial fibrillation is observed as we see and in overt hyperthyroidism, it is more common than in subclinical hyperthyroidism. And subclinical hyperthyroidism, we have a topic that will be covered, inshallah, in the coming few hours. Even subclinical hyperthyroidism is associated with increased rate of atrial ectopy. This is another type of arrhythmia and a threefold increase of atrial fibrillation. In 60% of hyperthyroid patient with atrial fibrillation, the rhythm converts spontaneously to sinus rhythm when the hyperthyroidism is treated. In one study, all who spontaneously converted did within 4 months after becoming euthyroid. Among those who do not convert spontaneously to sinus rhythm and who undergo successful electrical cardioversion, the two-year risk of recurrent atrial fibrillation was 59% compared with 83% of patients whose atrial fibrillation was not associated with hyperthyroidism. The role of anticoagulant, this is a very important issue. Please, you have to know that any patient with hyperthyroidism and atrial fibrillation, there is indication to go for anticoagulation. Why? Because arrhythmia within the heart may lead to clot formation, thrombus formation, and emboli maybe will be circulated in the bloodstream, leading to ischemia or embolism in the different parts of the body. Embolism, different areas of the body should be prevented by using anticoagulant. The anticoagulant, as I told you before, is is indicated in cases of hyperthyroidism and atrial fibrillation. The role of anticoagulant anticoagulation is controversial in the hyperthyroid patient with atrial fibrillation. In severe studied, about 40% of patients with hyperthyroidism and atrial fibrillation had atrial embolus. And in other references, it is indicated that anticoagulation should be given. And this is usually the trend we are seeing in the clinical practice. Left atrial enlargement, which is a risk factor for thrombus formation, is present in about 90% of cases of hyperthyroidism thyroid patient with atrial fibrillation, and 2% of hyperthyroidism patient with sinus rhythm. Based on these results, we usually anticoagulate hyperthyroid patient with atrial fibrillation. This is the recommendation. So, recommendation in the agreement with guidelines published 2006 by the American College of Cardiology and American Heart Association and European Association of Cardiology, Society of Cardiology as well, is to go for anticoagulation in these cases. So, please, if you like to have one information in this topic, please remind this information. I know all informations are important, but is one of the most important that is easily missed in the clinical practice. And it is, as we see, it is crucial because if you miss it, it means patient will go for thrombus and emboli. Definitely, patient will go for ischemia or whatever complication that is observed in these cases. Other abnormalities including mitral valve prolapse, mitral regurgitation, and increase in left ventricular mass index also being reported. Let's go now for the next category, including metabolic or endocrine. We are observing that the serum lipid patient with hyperthyroidism tend to have low serum T total and high density lipoprotein, which is HDL cholesterol concentration, and low total cholesterol HDL cholesterol ratio. These values increase after treatment. What about hyperglycemia? Again, hyperglycemia observed as well, although thyroxine is not a counter-regulatory hormone, but hyperthyroidism can interfere with glucose metabolism, and it is associated uh, 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 um, it is associated with both increased sensitivity and pancreatic beta cell to glucose, pancreatic beta cell to glucose, resulting in increased insulin secretion and antagonism to the peripheral action of insulin. So this is the pathogenesis in which we are seeing why we are seeing hyperglycemia in cases of thyrotoxicosis. The latter effect usually predominate, leading to impaired glucose tolerance in untreated patients. So please keep it in your mind that maybe you see hyperglycemia in these cases, and this is the pathogenesis seen here. Adrenal function, interpretation of the cortisol response to ACTH stimulation testing may be misleading in patients with hyperthyroidism because cortisol binding globulin level decrease, resulting in a lower total serum cortisol concentration. So maybe sometimes you have to go for another test or to go for clinical judgment. In one report of 49 hyperthyroid patients undergoing ACTH testing, 35% had subnormal total serum cortisol value less than 18, while only 11% had a normal, subnormal free cortisol index. What are cases or symptoms and signs or clinical presentations related to the respiratory system? Dyspnea, the dyspnea on exertion may occur for many reasons in hyperthyroidism. Oxygen consumption and CO2 production increase. These changes result in hypoxemia and hypercapnia, respectively, both of which stimulate ventilation. Respiratory muscle weakness is an important cause of dyspnea as well, and reduced exercise capacity or intolerance may be largely due to respiratory muscle weakness and decreased lung volume reduced. There may be tracheal obstruction from a large goiter. Hyperthyroidism may exacerbate underlying asthma. Pulmonary arterial systolic pressure is increased as well. What about gastrointestinal or GIT symptoms and signs or clinical presentation? We have following. Maybe you can observe weight loss, which is due to increased metabolic rate as a primary cause, hypermetabolism, and secondary to increased gut motility and the associated hyperdefecation and malabsorption. Rare patients have steatorrhea. Celiac disease is also more prevalent in patients with Graves' disease, which we know the underlying mechanism is autoimmune. So that's why we have observing, or we are observing this association. Next, we are seeing most patients have hyperphagia, also observed in these cases, but an occasional patient with mild hyperthyroidism may have sufficient appetite stimulation that weight is gained more commonly in younger patients. So it is or sometimes observed that weight gain is seen in patients with hyperthyroidism, but it is actually rare in the clinical practice. Anorexia may be prominent in older population with hyperthyroidism, one of the important issues. Second one, other changes that may occur, including vomiting and abdominal pain, which is seen rarely, dysphagia due to goiter, abnormalities in the liver function test, particularly high serum alkaline phosphatase concentration, and rarely cholestasis. What about the hematological manifestations? The red blood cells mass is increased in the hyperthyroidism, but the plasma volume is increased more, resulting in a normochromic normocytic anemia. Serum ferritin concentration may be high. Graves' hyperthyroidism may be associated with autoimmune hematological disorders such as idiopathic thrombocytopenic purpura and pernicious anemia, and some patients have anti-neutrophil antibodies also. Hyperthyroidism may also be a prothrombotic status, so patient may have thrombus, as we mentioned before. An example, in one small study of thyroid carcinoma, patient taking levothyroxine in doses causing mild hyperthyroidism, level of fibrinogen prothrombin fragment 1+2 protein S antithrombin TBA BAI and BAI TBA were significantly higher than in euthyroid control. Overt hyperthyroidism patients have increased von Willebrand factor, one of the factors in the coagulation cascade, and shortened in vitro platelets plus formation times, indicating enhanced platelets function. Genitourinary. The genitourinary symptoms or clinical manifestations observed here, including urinary frequency and nocturia, which are more common in hyperthyroidism, although the mechanism is uncertain. Possible causes include primary polydipsia and hypercalciuria. Enuresis is more common in children as well. In women, serum 6 hormone binding globulin, which is called SHBG, concentration are high, which results in high serum estradiol concentration and low normal serum-free unbound estradiol concentration, high serum LH concentration, luteinizing hormone, and reduced mid-cycle surge in LH secretion, oligomenorrhea, and ovulatory infertility. Amenorrhea can occur in women with severe hyperthyroidism as well. What about the presentation related to genitourinary tract in men? We can see increase in serum SHBG concentration results in high serum total testosterone concentration, but serum-free unbound testosterone concentration are normal or low. Serum LH concentration may be slightly high as well. Serum LH concentration may be slightly high, as I told you, and extragonadal conversion of testosterone to estradiol is increased so that serum estradiol concentration are high. These changes can cause gynecomastia, reduced libido, erectile dysfunction. So if you are seeing erectile dysfunction, reduced libido, gynecomastia in male patient, you have to think of hyperthyroidism as a differential diagnosis. Spermatogenesis is often decreased or abnormal. More spermatozoa are abnormal or non-motile as well. What about the bone clinical manifestation? Thyroid hormone stimulate bone resorption, resulting in increased porosity of cortisol bone and reduced volume of trabecular bone. The loss in cortical bone density is greater than that of trabecular bone. Serum alkaline phosphatase and osteocalcin concentration are high, indicative of increased bone turnover. The increase in bone resorption may lead to an increase in serum calcium concentration. Therapy inhibiting parathyroid hormone secretion and conversion of calcidiol 25-hydroxy vitamin D to calcitriol, which is active form 125-hydroxy vitamin D is seen. So, in addition, the metabolic clearance rate of calcitriol is increased. The changes can result in impaired calcium absorption and an increase in urinary calcium excretion. The net effect is osteoporosis and increased fracture risk in patients with chronic hyperthyroidism. So we are suspecting osteoporosis in cases of hyperthyroidism. So maybe you have to go for DEXA scanning and bone mineral density measurement to look for the osteoporosis in cases of hyperthyroidism related to the bone disorder. What about neuropsychiatric manifestations? Patients with thyrotoxicosis may experience behavioral and personality changes such as psychosis, agitation, and depression. So one of the differential diagnoses in psychiatric illness is hyperthyroidism as well. Less overt manifestations that are more common in less severe thyrotoxicosis include anxiety, restlessness, irritability, and emotional liability. Insomnia is also common. Symptoms often worsen in patients with pre-existing psychiatric disorder. These behavioral manifestations are accompanied by cognitive impairment, particularly impaired concentration, confusion, poor orientation, and immediate recall, amnesia, and constructional difficulties. What about the presentation in the older population? Geriatric hyperthyroidism in elderly patients may be apathic rather than having hyperactivity tremor, other symptoms of sympathetic overactivity. Two-thirds of such patients have symptoms similar to those in younger patients. In cross-sectional studies of patients with hyperthyroidism, older patients had a reduced risk of presence of several classical symptoms like heat intolerance, tremor, nervousness, but a higher prevalence of weight loss and shortness of breath compared with younger patients. Older patients had a higher rate of atrial fibrillation also and a moderate to severe ophthalmopathy. Older population also with Graves' hyperthyroidism are less likely to have a goiter. Toxic multinuclear goiter is more common in elderly, although the majority of hyperthyroidism patients at any age have Graves' hyperthyroidism. In addition, elderly patients often have persistent constipation, tachycardia of 100 beats per minute, and is absent in 40% of elderly hyperthyroid patients due to primarily coexistence. Uh, uh, sorry. Coexisting conducting system disease. So maybe you are seeing tachycardia or absent of tachycardia also in elderly. So the manifestation in elderly may be different than in younger population, or we can say atypical presentation. In patients in whom hyperthyroidism is suspected, recommend the following. So what should you do? You have to go for measurement of TSH concentration as initial screening test. If subnormal serum free T4 and T3 concentration are run by most laboratory. If not, but the index of suspicion for hyperthyroidism is high, a free FT4, 3T3 should be ordered with an initial TSH measurement. So step number one, TSH, if it is suppressed or subnormal, go for measurement of free T4 and free T3. We are suspecting to see high levels of FT3 and FT4 in cases of hyperthyroidism. If serum TSH is low and a serum free T4, T3 are high, diagnosis of hyperthyroidism is confirmed. The next step is radioactive iodine uptake scanning. I see many clinical clinicians, unfortunately, immediately treating the patient with and with no uptake scanning order. Uptake scanning order will give you, as I mentioned earlier, the differential diagnosis, maybe it is thyroiditis, so no need for anti-thyroid medication in these cases. Toxic nodular goiter usually need radioactive iodine ablation as the main treatment or the best treatment option. Graves' disease need medication is the as the initial therapy usually, or radioactive iodine can be given. So you have to go for radioactive iodine uptake scanning to differentiate between different causes of hyperthyroidism. So if free T4 and T3 are high, but TSH is normal or high, particularly MRI should be done. It means patient may have TSH secreting adenoma. If there is no pituitary mass, but there is end organ evidence of hyperthyroidism, a careful family pedigree should be obtained, as well as genetic testing for possibility of thyroid hormone resistance. If TSH is low, serum T3 but not free T4 concentration is high, the patient most likely have Graves' disease or autonomous functioning thyroid adenoma, toxic adenoma, I mean. Possibility of exogenous T3 ingestion should also be considered. If the pattern of low TSH seen with high serum free T4 and normal T3 concentration, usually it suggests hyperthyroidism also with concurrent non-thyroidal illness, amiodarone therapy, or exogenous T3, T4 ingestion as a differential diagnosis. Patient without overt signs of hyperthyroidism in the setting of low TSH and normal free T4 and T3 concentration most likely have subclinical hyperthyroidism. Other possibility include central hypothyroidism, non-thyroidal illness, recovery from hyperthyroidism, early pregnancy, possibility of a normal finding in some healthy older people. So this is the differential diagnosis of hyperthyroidism, as you can see here. So I will not go for details, but quickly for toxic adenoma or toxic multinodular goiter, TSH will be low with high FT4 or normal FT4 and T3. Graves' disease is the same. Postpartum thyroiditis the same. So how we can differentiate? Antibodies like TSH secreting anti-TSH antibodies seen in cases of Graves' disease. It is absent usually in toxic adenoma. The uptake scanning, as we mentioned before, the main important issue, it will be normal or high in Graves and toxic nodular goiter, and low in cases of the thyroiditis. Toxic adenoma and toxic nodular goiter, which is the main focus here, are a result of focal or diffuse hyperplasia of thyroid follicular cells whose functional capacity is independent of regulation by TSH. Activating somatic mutation of genes for TSH receptor have been identified in both toxic adenoma and nodules of toxic multinodular goiter. Similarly, activating mutation of GS alpha protein have been identified in toxic adenoma, but it is uncertain whether they occur in toxic multinodular goiter. Other mutation must also play a role because in one study mutation in neither of these genes were found in 15 toxic adenoma cases. Toxic multinodular goiter and toxic adenoma frequently result from a somatic mutation in G alpha subnet of or TSH receptor causing constitutive activation in one or more nodule, which lead to autonomy of function and the secondary thyrotoxicosis. This is the pathophysiology of toxic adenoma. Recent exposure to iodine should be determined because acute iodine load either in diet or intravenously from medical testing, like if the patient going for radiological test or radiological imaging using dye, or the patient going for whatever the use of dye, like MRI, CT, I mean, either in the diet or intravenously from medical testing can lead to what we call iodine-induced thyrotoxicosis in patients with pre-existing thyroid autonomy. This a category called Joule-Bossoudo phenomena. So if the patient has a contrast, definitely you have to think about hyperthyroidism. I mean, maybe due to this dye. So one of the differential diagnosis is the using these, if the patient using contrast, maybe you think about it. Next, physical examination may reveal one or more palpable nodule in the neck of the patient. So maybe one nodule, maybe multiple nodules, and overall gland enlargement can be seen in cases of Graves. Patient can be asymptomatic or exhibit classic symptoms of thyrotoxicosis. Obstructive symptoms can occur if the gland is large, especially if the patient has significant substernal extension. So you have to ask every patient with a goiter about symptoms or signs of compression. What are the compressive symptoms that may indicate surgery? Compressive symptoms that may indicate surgery in any patient with goiter, including difficulty in breathing and difficulty in eating, like dysphagia. So in these cases, direct your patient to have a consult from a surgeon. This is very important. With toxic adenoma, a thyroid scan will reveal solitary overactive HOT, as I showed you before, with separation of non-autonomous extranodular tissue. In contrast with toxic multinodular goiter, a thyroid scan will reveal patchy uptake of a radioactive iodine with increased uptake in autonomous region and reduced uptake outside those area. In area of decreased uptake, determining if the reduced uptake correlate with a normal appearing tissue or a distinct thyroid cold nodule is essential, because The latter requires specific evaluation, including aspiration. I think Dr. Humaid yesterday, he talked about nodule, thyroid nodule, and how to go for fine needle aspiration indication. One of the indications, just a reminder, if you are doing thyroid uptake scanning and you find a cold nodule, please go for fine needle aspiration. Maybe it is malignancy or discovering malignancy can be seen. Ultrasonography is useful in assessing toxic nodular goiter because scan finding can be correlated with the normal thyroid architecture, and functional nodule can be delineated from non-functional one. Iodinated contrast should be avoided in patients with toxic thyroid nodule if possible, and close monitoring by thyroid function test is indicated. Antithyroid drugs can achieve drug-free remission in Graves' disease, as Dr. Hamid told you, but this is the issue here. Only modulate thyroid hormone production in toxic multinodular goiter and toxic adenoma, and thus would be required continuously to control hyperthyroidism, and maybe radioactive iodine will be the definitive treatment, ablation in these cases. In contrast, radioactive iodine can be definitive treatment in toxic multinodular goiter and toxic adenoma because hyperactive nodule take up the iodine with suppressed normal tissue receiving minimal radiation exposure. As the hyperthyroidism tissue is destroyed over the subsequent few months, the residual normal tissue resume function, which allow a return to euthyroid without a need for thyroid hormone replacement therapy. Surgical options include removal of the involved loop in toxic adenoma and total thyroidectomy in toxic multinodular goiter. Patients who undergo total thyroidectomy will require lifelong levothyroxine therapy, definitely, but those who have only the involved loop resection may have enough residual tissue to remain euthyroid. So usually if the patient has total hyperthyroidism, maybe, total thyroidectomy, will have hypothyroidism in remaining of life and need replacement with levothyroxine in the remaining life. But if the patient has a residual tissue, like maybe lobectomy was done, maybe patient not require daily thyroxine, and frequent monitoring is usually suggested. Mutation of TSH receptor gene are most common in one study. They were found in 15 of 31 toxic adenoma. The mutations are usually in the transmembrane domain of the receptor, but can be in the extracellular domain. The mutant receptor activate adenyl cyclase in the absence of TSH. Toxic multinodular goiter tend to be more common in area where iodine intake is relatively low, and in comparison, the frequency of thyroid adenoma is not related to iodine intake. So by this, I am done with the first topic. I hope it was interesting for all of you. Please, now I will go for the next topic. If you have any query at any time, maybe you can type it down in the chat box. So we will have a time for this discussion. Before going to break, I will try to cover the second topic. I know the second topic, it is a long one, but maybe we can try to have some of it before the break. So the second topic is thionamide in the treatment of Graves' disease. The introduction here that we know thionamide like methimazole, carbimazole, and BTU are effective treatment of patients with Graves' hyperthyroidism. They are actively transported into the thyroid gland where they inhibit both the organification of iodine to tyrosine residue in thyroglobulin and coupling of iodotyrosine. The clinical use and efficacy of thionamide in the treatment of Graves' hyperthyroidism will be reviewed here. The pharmacology and toxicity of these drugs as well as other treatment option of Graves' hyperthyroidism are reviewed separately later on. But to here, clinical use of thionamide, we are focused. Thionamide are often started in patients with Graves' hyperthyroidism to attain iothyroid state rapidly in preparation for radioactive iodine therapy or thyroidectomy. However, patients who want to avoid or defer ablative therapy with radioiodine or surgery can continue to have thionamide for a long period and sometimes whole life. Although hyperthyroidism can almost always be controlled as long as the drug is taken, only approximately 20 to 30% of patients achieve a permanent remission within 1 to 2 years of treatment. This estimate include patients with severe disease in whom remission are unlikely, as well as patients with mild disease in whom remission rate may be high as 75%. Studies using long-term antithyroid drug for 5 to 10 years or longer have reported remission rate as high as 84%. Patients treated with thionamide take 3 to 8 weeks or longer to become euthyroid because they block new hormone synthesis and any already formed T4 and T3 stored in the colloid must be secreted and metabolized for clinical improvement to occur. Contraindication to antithyroid, including thionamide drugs with previous major adverse reaction like agranulocytosis, hepatotoxicity, and pancreatitis, because they are teratogenic. Their use in women desiring a pregnancy in the next year or two require a careful discussion because there are risks and alternative treatments such as definitive treatment prior to conception, like radioactive iodine ablation, and waiting for about 6 months or surgery should be considered in these cases. Initiation of the thionamide, the approach outlined below is largely consistent with hyperthyroidism management in the ATA, American Thyroid Association guidelines. The choice of the drug like BTU and methimazole are the thionamide drugs available. Carbimazole also available, which is usually one of the best option available here in our country because of the availability. Carbimazole is completely metabolized to methimazole, although the carbimazole dose required to yield an equivalent dose of methimazole is approximately 40% higher. Although all of thionamide are effective for hyperthyroidism, methimazole and carbimazole have a number of advantages over BTU. Methimazole is preferred to BTU for many reasons, including more rapid achievement of euthyroid. Methimazole achieve euthyroid state more rapidly than BTU, especially in patients with more severe hyperthyroidism. In one randomized trial, methimazole 30 milligrams daily resulted in a higher percentage of patients with T4 more than 7 nanogram having normal free T4 level at 4, 8, and 12 weeks compared with BTU 30 milligram daily. For patient with free T4, less than 7 nanogram per deciliter, methimazole 30 or 15 milligram and PTU 30 milligram daily were equally effective at 4 and 8 weeks, but 30 milligram of methimazole was more effective than other two regimens at 12 weeks. The second reason, it is only once daily dose with a better compliance, little or no effect on subsequent success of radioiodine therapy. Methimazole is less likely than BTU to be associated with failure of radioiodine therapy when thionamide are given to normalize thyroid function before radioiodine treatment. 78% of patients pre-treated with methimazole and only 32% of patients pre-treated with BTU were cured by 10 millicurie dose of radioiodine. It is less toxic. There have been concern about BTU-associated hepatotoxicity, although hepatotoxicity is still a rare complication. ATA and FDA recommend BTU not to be prescribed as a first-line therapy in children or adults. However, there are some clinical situations or settings in which we prefer BTU. Number one, the first trimester of pregnancy. Number two, initial management of patients with life-threatening thyrotoxicosis or thyroid storm. Number three, patients with minor reaction to methimazole who do not want to have a definitive treatment with radioactive iodine or surgery. Rectal and intravenous preparation of methimazole and BTU can be prepared by hospital or compounding pharmacies for selected patients who are temporarily unable to take oral medication. There are many pre-treatment evaluation or can say items should be there before you start your treatment. Prior to initiating thionamide, we have to obtain a blood test, including complete blood count, CBC, especially white blood cells with differential and the liver profile, bilirubin and transaminase. Who do not, patient, usually you should not be given thionamide with a baseline absolute neutrophilic count less than 1,000 or elevated liver function test more than 5-fold upper limit of normal. This is again a very practical point. You have to go for liver function test before initiation of the therapy. If it is more than 5 folds, don't initiate, I mean liver function test, ALT, AST, transaminase. And if the WBC or neutrophilic count less than 1,000, don't initiate. Why? Because there is a risk to have more leukopenia and neutropenia with using this drug and more increase in the transaminase, which is more dangerous for the patient. Except in selected patients when alternative less attractive after careful assessment of alternative and risk. Yes, maybe you can use, but majority don't use it as first-line treatment. What about the dose? The initial dose of methimazole varies according to the severity of hyperthyroidism. Free T4, 1 to 1.5 times the upper limit of normal. Patients with small goiter and mild hyperthyroidism usually begin treatment with 5 to 10 milligrams of methimazole once daily. The dose can be increased if the hyperthyroidism assessed by clinical by clinician and by measurement of serum TSH-T4 is not corrected or improved within 4 to 6 weeks. Number two, if the free T4 with 1.5 to 2 times upper limit of normal, patients with moderate hyperthyroidism usually begin treatment with 10 to 20 milligrams of methimazole once daily. Really, the low dose regimen appear to be effective as a higher dose in this subset of patients. the dose is tapered to maintenance level 5 to 10 milligram per day as the patient is improving. Free T4 more high, it means 2 to 3 times above the normal. Usually patient with larger goiter and more severe hyperthyroidism should be treated with 20 to 40 milligram daily of methimazole, and administration can be given in divided doses like 10 milligram 3 times or 15 times daily, or even can be given once. But the benefit of giving the divided doses to minimize possibility of GIT or gastrointestinal side effect that can be seen in these cases. Again, as I told you, as a compliance issue, maybe you can give it at once daily dose. The dose is tapered to maintenance level 55 to 10 milligram as the patient improve. Few patients require 40 milligram daily of methimazole. The carbimazole dose is required to yield an equivalent dose of methimazole is usually 40% higher. For example, 10 to 20 milligram dose of carbimazole yields roughly 6 and 15 milligram of methimazole respectively. Our dose recommendations are influenced by the dose dependence of the major side effect of methimazole, usually thionamide and levothyroxine, which is called block and replace therapy, not recommended. It is an old-fashioned. If the patient went to hypothyroid, decrease or stop your antithyroid medication because it requires higher doses of thionamide, resulting in a higher rate of adverse effect. So just go up and down with your dose of the methimazole if needed according to the thyroid tissue. No need to concomitantly with thyroxine and carbimazole, which is called block and replace therapy. It is an old-fashioned. Block and replace may have a utility in those rare patients in whom thyroid function fluctuate above and below the normal range despite minimal change in methimazole dose. It may be also useful in pediatric population as well. But actually in the clinical practice, it is very rare to go with this approach. The dose recommended, supported by randomized trial in one study, over 30 patients, maybe you use methimazole 30 milligram, methimazole 15 milligram, BTU 30 milligram per day. The following results were observed. 12 weeks, the percentage of patients with normal free T4 level was 97, 86, and 78% in methimazole 30 milligram, 15, and BTU 30 milligram groups, respectively. Among patients with severe thyrotoxicosis, it means initial free T4 more than 7 nanogram, methimazole 30 milligram, normalized free T4 rapidly than methimazole or BTU. However, patient with free T4 concentration less than 7, there was no difference among the regimen used, BTU, carbimazole, or methimazole. T3 level were normalized more quickly with either methimazole dose compared with BTU, despite BTU ability to block T4 to 3 conversion, indicating that this effect is more important in short term rather than over many weeks. Side effects were seen in 30, 14, and 52% of patients taking methimazole, 30 milligram methimazole, 15 milligram, and BTU respectively. These data are supported by older study. For example, patient given methimazole in doses 15 milligram once daily, 30 milligram once daily, or 10 milligram 3 times daily became euthyroid in the same average time, while in a randomized trial, 509 patient, the response to 14 milligram per day of methimazole was somewhat more rapid than to 10 milligram per day. BTU rather than methimazole is used to treat hyperthyroid women during the first trimester of pregnancy, and for those initial management of life-threatening thyrotoxicosis or thyroid storm, dosing of BTU in this setting is reviewed separately later on. An alternative regimen that may be of utility, especially in patients experience dose-dependent minor side effect from methimazole, utilize both methimazole and in organic iodine in a study of patients with untreated gravis hyperthyroidism, free T4 more than 5 nanogram compared with patients who received 30 milligram methimazole daily, patients who were given 15 milligram methimazole and 38 milligram of inorganic iodine daily, achieved normal free T4 level more rapidly and had fewer side effects. What are the complications? Complications of thionamide therapy, including rare but serious side effects like leukopenia, agranulocytosis, as I told you, hepatotoxicity, and pancreatitis. It is preferred that information about serious adverse event given in patients with writing and discussed at in each follow-up. What about monitoring? Patients with Graves' disease who are treated with thionamide require monitoring of thyroid function, and for rare but serious adverse effect of thionamide like agranulocytosis, hepatotoxicity, and pancreatitis. Okay, I think now we have, it's already 4:15. It's the time for going for break, for taking a coffee break or going for prayer. And then we'll resume our topic starting from this slide, thyroid function. So in order to complete our topic, we have to go for break now, and we'll resume the topic, inshallah, after the break. The break inshallah will be from 4:15 till 5 p.m. So we have about 45 minutes to go for break. Don't be away, just go for refreshment, and inshallah 5 p.m. sharp will resume our topic. Thanks. Assalamu alaikum wa rahmatullah. Welcome everybody again to our session. To complete the previous topic that we have discussed in the first session about the antithyroid or antithyroid drug, including thionamide, of course. Some practical points I want to mention about the thyroid function. Patients with Graves' hyperthyroidism who are treated with a thionamide should have their thyroid function free T4 and total T3 initially assist at 4 to 6 weeks interval until stabilized on maintenance thionamide therapy. Once the patient has a normal free T4, total T4, the dose of methimazole can be decreased by 30 to 50%. Subsequent thyroid function test, including TSH if T4, should be repeated 4 to 6 weeks after each dose adjustment. A typical maintenance dose of methimazole 5 to 2 milligram daily when a stable maintenance dose is achieved. Thyroid function test can be performed every 6 months. So this is the how to monitor the thyroid function test while you are using anti-thyroid drugs in patients with hyperthyroidism. It is important to measure both serum FT4 and total T3 initially because serum T3 concentration may remain high even though serum free T4 concentration became normal. Serum T3 to 4 ratio is particularly high in Graves' hyperthyroidism, and I'm sure that T3 toxicosis of Graves' disease was mentioned yesterday by my colleague Dr. Hamid, in which you are seeing only T3 is high. And this is the answer of one of the question in the chat box or in the Q&A box. Should we measure both T4 and T3? Yes, because we have what we call it, T3 toxicosis. It is a variant of Graves' disease. So that's why maybe you are seeing FT4 normal and only T3 is high as a variant. So please, you have to go for both of them to exclude the issue of hyperthyroidism while you are assessing patients of hyperthyroidism. In comparison with the importance of serum T3 and T4 value, serum TSH value may be misleading during the initial period. Why? Because it may be stay suppressed for 6 months or more. So put in your mind that your target or your goal to decrease FT4 and FT3 if both of them are high. TSH is not your concern in the first stage. It needs time to be normalized, as you can see here. Pituitary TSH production is suppressed by hyperthyroidism, an effect that can persist for several months after T3 and T4 concentration become normal. As a result, serum TSH are often low despite normal or even low serum T4 and T3 concentration during first several months of treatment. The serum TSH concentration rises into the normal range within a few weeks. When this happens, there is no longer a need to measure serum T3 concentration. Importance of maintaining a biochemical euthyroid state in patient taking thionamide is suggested by a study that demonstrated increased all-cause mortality during treatment with thionamide and after radioiodine while still hyperthyroidism, but not after achieving hypothyroidism following radioactive or radioiodine. What about the adverse effect? We know every drug had adverse effect related to the drug. So controversy exists as to the value of monitoring white blood cell count. We do not routinely monitor white blood cell for development of agranulocytosis or liver function test for development of hepatotoxicity in patient thionamide, but CBC should be obtained during any febrile illness at the onset of pharyngitis. For example, we advise patient taking thionamide to discontinue drug at the earliest sign of fever, sore throat, or other infection until the result of white blood cell is available, because maybe there is agranulocytosis as a side effect. Liver function should be assessed in patients with signs or symptoms of hepatitis, like, for example, jaundice or light colored stool or dark urine or pruritic rash. Amylase lipase should be measured in patients with nausea, vomiting, and abdominal pain. Patients should be instructed to discontinue thionamide and contact the clinician when there are such symptoms. What is the approach to stop the therapy? First of all, duration of the therapy. Methimazole in preparation for radioactive iodine ablation. This is number one category. Radioiodine can be administered as initial therapy for hyperthyroidism without methimazole pre-treatment in most patients with hyperthyroidism, especially if they are receiving adequate therapy with beta blocker. But sometimes, particularly older population and those who are susceptible to hyperthyroidism, effect of hyperthyroidism, like maybe toxic storm, can be treated with methimazole in the beginning until euthyroid, and then we can administer the radioactive iodine ablation. For such patient with graves hyperthyroidism taking methimazole to attain euthyroid state rapidly in preparation for radioactive iodine therapy, it is typically pre-treat with methimazole for 2 to 6 weeks. If it is euthyroid, then you can administer the radioactive or radioiodine can be given or administered once serum TSH concentration in the normal range. Usually we stop methimazole 3 days before radioactive and we can start 3 days after radioactive iodine can be given again to allow better control of thyroid function post radioactive iodine. What about methimazole in preparation for thyroidectomy? Patients with hyperthyroidism undergoing thyroidectomy are at risk for developing a thyroid storm, a rare condition that usually occurs during surgery or in the first 18 hours of the procedure. Thus, patients with hyperthyroidism who are treated with surgery should receive pre-treatment with methimazole until they are euthyroid. Typically for 4 to 6 weeks, surgery can be performed. Once serum TSH concentration in the normal range, methimazole can be discontinued on the day of the surgery. Methimazole as a primary therapy. For patients taking methimazole as a primary therapy, it should be initially be continued for 12 to 18 months. So this is the duration of the antithyroid drug in the clinical practice, 18 months usually. In some references, up to 24 months complete to complete 2 years. It is best to agree with the patient on tentative duration of therapy when treatment is begun, and then to re-examine the treatment option and goal at the end of this period. However, methimazole can be stopped at any time to allow patient to proceed with the radioiodine or surgery. On the other hand, if remission is not obtained after 12 to 18 months course of methimazole, long-term treatment with methimazole for 10 years or more has been shown to be effective and safe. Remission rate are lower if patients are treated for less than 18 months. In one randomized study of treatment duration, 94 adults were treated with carbimazole for 6 to 8 months with respective rate of relapse of hyperthyroidism in 2 years after cessation of therapy of 58 and 38%. These results support the addition, recommendation given above for initial 12 to 18 month period of treatment. Evaluation prior to stopping therapy. This is very important in patients with normal thyroid function test. Typically, measurement of anti-TSH receptor antibodies, either using thyroid stimulating immunoglobulin, TSI, or tropin binding inhibiting immunoglobulin TBII initially after 12 to 18 months of thionamide therapy, patients with normal level have a greater chance for remission, up to 80% once thionamide are discontinued. Thus, thionamide can be discontinued if TRAb and TSH are normal at 12 to 18 months. Patients require monitoring for recurrence. Every 2 months in the beginning, you have to go for thyroid function test, and maybe after that, you go for monitoring every 4 to 6 months. Persistent high level of TRAb are associated with very high relapse rate, and such patients should either continue methimazole or proceed with definitive therapy like radioactive radiotherapy or surgery. In some patients with borderline elevated antibody level who want to be certain that they need definitive treatment, methimazole can be discontinued, and they should be monitored frequently, as we mentioned before, and plan for definitive therapy with radioiodine or preparation for thyroidectomy as soon as recurrent hyperthyroidism documented. There is an extensive literature regarding various tests such as serum TRAb measurement that can be done during treatment with thionamide to predict whether a patient has achieved remission of underlying Graves' disease. An example, in one study, 97% of patients with TRAb 3.85 international unit per liter relapse. In this same study, 80% of those patients with TRAb less than 2 remained euthyroid for a median follow-up period of 15 months. Another study found a high serum TSH binding inhibitory activity after 18 months of treatment in 60% of patients who relapsed and 15% who remained in remission. Monitoring of recurrence, the frequency of prolonged remission among patients treated with thionamide for 1 to 2 years is usually under 40%. Thus, after discontinuation of thionamide, patients require monitoring for recurrent hyperthyroidism. For patients with normal TRAb and TSH at 12 to 18 months, thionamide are discontinued, and serum TSH free T4 and total T3 are measured initially at 2 to 3 months interval, beginning 2 to 3 months after stopping treatment or earlier if the patient notes recurrent hyperthyroidism symptoms. Using this approach, recurrent biochemical hyperthyroidism is usually detected before patient develop many symptoms. So this is very important. It is practically can be done to detect recurrence by monitoring of thyroid function test before symptoms appear. So this is the purpose of our frequent monitoring. Please go for monitoring to detect early recurrence before symptoms appear to the patient. Suppressed TSH level in the defiance of normal free T4 T3 is predictor for relapse. If thyroid tests remain normal for 6 months, monitoring should occur at 4 to 6 months interval, as we mentioned before, for the next 6 months, and then every 6 to 12 months after that. Patients who remain euthyroid for a year, TSH can be performed annually. Time course of relapse, recurrent hyperthyroidism is initially manifested by low TSH concentration. The time relapse is related to the presence or appearance of presence or absence of TRAb. In antibody-positive patient, relapse can occur as soon as 10 days after drug cessation, while in antibody-negative patient, it can take many months or even years for recurrence to develop in that fraction of patient who eventually recur. Prolonged remission is likely if the patient remain euthyroid for 6 months. So if your patient is euthyroid for 6 months, so prolonged remission can be observed or seen in this patient. Late relapse occur in 8 to 10% of patients. It is also, we can say, seen in cases or reported in cases in about 10%, maybe you can see later relapse. Who remain euthyroid for 6 months. Recurrence are particularly common in postpartum period in women who were previously in remission after thionamide treatment. For patients with recurrent hyperthyroidism after a course of methimazole, radioiodine surgery, or a longer course of methimazole, or are reasonable options to be given. Definitive therapy is preferred by some patient radioiodine or thyroidectomy, but long-term methimazole is alternative option which is preferred by majority of the patient to be definitive therapy through whole life. However, antithyroid drugs are teratogenic and therefore long-term therapy in women in childbearing age require a careful discussion of risk and alternative. If long-term methimazole choosing, TRAb level can be monitored every 1 to 2 years with discussion of discontinuation of methimazole. If TRAb level become negative with long-term therapy, such patients require monitoring for recurrence. Rate of prolonged remission, the frequency of prolonged remission among patients treated with thionamide for 1 to 2 years has been variable, reported. 15 to 80%, but it is usually under 40%. After 5 to 10 years of treatment, remission reported as high as 84%. The remission rate may be higher in patients whose dietary intake of iodine is low. So very important that you have to see that the remission rate may be higher. So maybe you advise your patient to have a low dietary iodine intake in order to have a better remission rate. A question that remains unresolved is whether the remission that are associated with thionamide therapy are due to the drug or the natural history of the disease. Example, spontaneous remission rate in a group patient treated with propranolol alone was 30%, similar to that in patient treated with thionamide. It means maybe patient in these cases may be treated symptomatically with beta blocker, and because of the natural history of Graves' disease, it is autoimmune. With the time, the autoimmune process becomes less and patient improved. Although, or maybe because you are because it is observed that although these patients have similar have mild hyperthyroidism, this observation support the hypothesis that thionamide primarily, but time for spontaneous remission to occur. On the other hand, the remission rate after 12 to 18 months of thionamide treatment in patients with mild disease may be as high as 50 to 75%. Predictor of remission, because remission rate among patients treated with thionamide are variable, establishing criteria to predict the likelihood of remission when the patient is the first teen would be helpful in discussion of treatment option with the patient. Clinical factors, several clinical factors have been associated with likelihood of remission, is as illustrated by the following observational studies, including remission rate were higher in female and in patient with mild hyperthyroidism, small goiter or a goiter that reduced in size during thionamide therapy compared with large goiter, age over 40 years, cessation of cigarette smoking also increased the chance of remission. Remission rate were lower in patients with severe ophthalmopathy, men compared with women, 20 versus 40%, patient under age of 40 compared with older patient and children. What is the role of thyrotropin receptor antibody? In many studies, the concentration of thyrotropin receptor antibody TRAb and the pattern of change during thionamide treatment correlate with the chance of ultimately achieving remission. As an example, in one study, patients who were initially TRAB negative and higher remission rate than those who are antibody positive. In other studies, disappearance of TRAB during thionamide therapy was associated with 70 to 80% chance of remission. That's why some guidelines recommend to go for measurement of antibodies before discontinuation of the treatment as a predictor for the future remission or relapse of the disease. Three different patterns shows changes in TRAB level over time have been described in patients on long-term thionamide. Number one, decreasing TRAB level. In one study, 549 patients on antithyroid drug for 8 years or more, 226 patients had a smooth fall in TRAB level, and 89% of them went into remission. In a retrospective analysis of similar study, level of TRAB that fell within 2 to 3 years of treatment were associated with 50 to 60% remission rate. Fluctuation TRAB level in the study of 549 patients described above, 207 patients had fluctuation TRAB level and only 37% of them achieved a remission. In the retrospective analysis, fluctuation level of TRAB that become low after 8 years of anti-thyroid drug were associated with a 30 to 40% remission rate. Persistent elevated TRAB level, this is the third category in the retrospective analysis. Persistently elevated TRAB level were associated with only 10% rate of remission. What is the role of thionamide dose? Although the initial response is faster with higher dose than the lower dose, eventual relapse rate appears similar. Side effects are more common in higher dose, of course. Let us see some studies about the dose. A study from Brazil concluded that higher dose of thionamide resulted in a higher remission rate, but the patient received high dose therapy, required co-treatment with T3 to prevent hypothyroidism. The remission rate was 75% in group receiving high dose thionamide and T3 therapy versus 42% in group receiving low dose thionamide therapy alone, and side effects were more common with higher dose. In the European multi-center center trial in which all patients were treated with T4, biochemical euthyroid was achieved more quickly with 40 milligram compared with 10 milligram dose, but the rate of remission were similar for two doses. Side effects were more common with higher dose. Prospective Japanese study of two doses of methimazole, 10 milligram 3 times daily versus 15 milligram once daily, found no difference in response between the two doses. In addition, there was no difference in the rate of recurrent hyperthyroidism after 6 years. In another study that compared 20 milligram with 40 milligram per day after 4 hours, serum T4 concentration were lower in patients receiving 40 milligram after 6 weeks and adjustment of the dose to avoid hypothyroidism. The mean concentration were similar, but more patients receiving 40 milligram developed transient hypothyroidism. Longer duration of therapy improve remission rate, which have been reported to be high as 84% after 5 to 10 years of treatment. In children, remission also rate increased from 25% to 75%. The role of combination therapy with T4, as we mentioned before, it is minimized nowadays, and it is not practically to go for this approach. What is the mechanism of remission? There are 3 mechanisms where patients with Graves' disease can achieve spontaneous remission. Number 1, a fall or disappearance of TRAB, which is anti-TSH receptor antibody. Number 2, destruction of functioning thyroid tissue by extensive lymphocytic infiltration, similar to chronic lymphocytic thyroiditis. Hashimoto thyroiditis may prevent the gland from responding to TRAB and can eventually result in spontaneous hypothyroid. Serum antithyroid peroxidase antibody concentration correlate with the degree of lymphocytic infiltration, and patients with higher concentration have a higher rate of spontaneous remission of Graves. Rarely, remission can be associated with appearance of thyrotropin receptor blocking antibodies. It is called thyroid blocking immunoglobulin, which occupy the thyrotropin receptor and block stimulating action of TSH or TRAP. These patients can spontaneously develop hypothyroid and occasionally fluctuate between hyperthyroidism and hypothyroidism state, depending on the relative titer of stimulating and blocking antibodies. I have one patient with this scenario, sometimes going for hyper, sometimes going for hypo. Once she is in hypo state, I'm treating her with levothyroxine. Once she is in the hyperthyroid state, I'm treating her with carbimazole, and she is refusing the thyroid uptake, thyroid treatment, radioactive iodine treatment, and surgery. That's why I'm trying to go with this approach. Now it's the time to go for some videos, to go for illustration for the summary of anti-thyroid drug. So please concentrate to summarize what we mentioned before.
Hi everyone. Today in this video, let us discuss about the anti-thyroid agents. Hyperthyroidism is one of the conditions where there is an excessive release of the thyroid hormones like the T3 and T4, and sometimes this disorder may also result because of the autoimmune disorder. For example, the Graves' disease, excessive thyroid hormones are going to be released, which results in the hyperthyroidism. Particularly in the hyperthyroidism, the basic metabolic rate is going to be increased because of the increased levels of the thyroid hormones, which may result in the variable effects on our physiological system. Generally, fatigue is observed in the patients, and because of the increased levels of the thyroid hormones, irritability and nervousness is observed in the patients. And it also affects the heart to produce irregular heartbeat. So palpitations can be observed, which may be irregular. And insomnia, lack of sleep, is another important disorder that can be observed with the hyperthyroidism. And apart from these symptoms, it can also produce tremor in the patients, diarrhea. It can alter the movement of the bowel, which results in the diarrhea, and protrusion of the eyeballs. Particularly, Graves' disease is associated with the protrusion of eyeballs, so that's why it is called as exophthalmic hyperthyroidism. And other symptoms like muscle weakness and hyperthermia can be observed with the hyperthyroidism. That's why thyroid hormone levels should be strictly controlled in order to prevent the dysfunction of the many of the organs. So today in this video, let us see what are the anti-thyroid agents that can be used to control the hyperthyroidism. So what are the various approaches to control the hyperthyroidism? When our thyroid hormones are excessively released because of the enlargement of the thyroid gland, we can use the radiation therapy, which use the radioiodine, iodine 131, that releases the beta radiation, which causes the destruction of the thyroid globules. Thereby it can decrease the hyperthyroidism. Otherwise, the thyroid gland can be surgically removed such that we can prevent the excessive release of the thyroid hormones. And finally, we can use the anti-thyroid agents, which are going to inhibit the synthesis of the thyroid hormones within the thyroid follicles. So in this video, let us discuss the anti-thyroid agents. So what are the anti-thyroid agents? Based on the type of use, these anti-thyroid agents can be classified into two types: the drugs which are used for the treatment of the hyperthyroidism, otherwise the drugs which are used as adjuvants. Adjuvants are the drugs which are used either pre or post-operatively, either to reduce the size of the thyroid hormone or to prevent what are the side effects during the surgical removal of the thyroid glands. And we can use the beta blockers like the propranolol and nadolol, which are non-selective beta blockers, which are going to block the beta 1 receptors on the cardiac system. Thereby they prevent the cardiac stimulation by thyroid hormones. Similarly, we can use the glucocorticoids like the prednisolone, which can control the inflammation, and calcium channel blockers like the verapamil, which can control the blood pressure. And finally, the iodide, the excessive iodide, can be given as a Lugol solution to decrease the size of the thyroid gland such that it can be removed by the surgery. In this way, we can use few of the drugs which are used as adjuvants, but here the Lugol solution can also be used in the thyroid storm in order to reduce the excessive symptoms. Then what are the drugs which are used for the treatment of the hyperthyroidism? So here the antithyroid agents mainly used for the treatment are the thiourines. So now the antithyroid agents are mainly used for the treatment of the hyperthyroidism and they are chemically classified as thiourines. So what are the thiourines? You can see that this is the structure of the thiourea, and if we are going to modify this thiourea and we are going to close the ring either with a 5-membered or 6-membered ring system, then they can produce the thiourines. So here you can see this is one type of drugs where the thiourea is going to be closed with a 6-membered ring system, and this is having the uracil-like structure. So this is nothing but the 2-thiouracil. Similarly, second type of drugs are having the thiourea, which is closed as a 5-membered ring system, and here what are the ring system is the imidazole. So this is nothing but the 2-thioimidazole. So this is the first one, propyl thiouracil. You can observe it is having the uracil structure with a propyl side chain at the 6th position. So this is the 6 propyl 2-thiouracil. Similarly, this is the another structure which is having an imidazole nucleus with a thiol group at the 2nd position. This is nothing but the methimazole. So methimazole is nothing but the 1-methyl 2-thioimidazole. Similarly, second one is the carbimazole. Carbimazole is having the similar structure with a ethyl carboxylate ester at the one of the nitrogen. So that is a carbimazole. So these are the 3 drugs which are used as antithyroid agents. Now let us see how these antithyroid agents can inhibit the synthesis of the thyroid hormones. So this is the plasma and this is the thyroid follicle, and this is the lumen of the thyroid follicle which is having the colloid. Now from the plasma, iodide is going to be absorbed into the follicle where it is going to iodinate the tyrosine residues to produce the thyroid hormones. But here one of the important step is the uptake of the iodide. So one of the pump present here is the NIS, sodium iodide transporter. And another pump is also present on the inner membrane. So this is a pendrin protein which is going to uptake the iodide at the inner membrane. Now the iodide can be transported along with the sodium into the follicles, and within the thyroid follicle the thyroglobulin is present which is attached with the tyrosine residues. These tyrosine residues can be iodinated by the iodide. Now the iodine molecule can attach to this tyrosine residue such that either one iodide molecule can be attached to the one tyrosine residue, otherwise the 2 iodide molecules can be attached to the one tyrosine residue. And this reaction is mediated by thyroperoxidase enzyme, and this enzyme is responsible for the iodination of the tyrosine residues in presence of hydrogen peroxide. Now in presence of thyroperoxidase enzyme, tyrosine residues are going to be iodinated such that they can form the monoiodinated tyrosine residues or diiodinated tyrosine residues, which we have represented here with the letters M and D. Now this thyroglobulin can be secreted into the thyroid follicle along with the monoiodinated and diiodinated tyrosine residues. But within the thyroid follicle, one of the enzymes is the lysosome, which is responsible for the dissolution of these thyroid globulins to release the free iodinated tyrosine residues. And in the next step, thyroglobulin can undergo the endocytosis and it can be present in the lysosome, which produce the cleavage of these tyrosine residues. Now here monoiodinated tyrosine as well as diiodinated tyrosine can be combined. Otherwise, one molecule of the diiodinated tyrosine and another molecule of the diiodinated tyrosine can be combined. So when the 2 molecules of the diiodinated tyrosine residues are going to be joined, they can produce a T4 which is going to be secreted into the plasma. Similarly, a monoiodinated and a diiodinated tyrosine residues can produce a T3 which can be secreted into the plasma. In this way, T4 and T3 are going to be secreted into the plasma from these iodinated tyrosine residues. Now let us see what is the action of these thiourines. Thiourines can inhibit one of the important crucial steps. They can inhibit the thyroperoxidase enzyme activity. By inhibition of this enzyme, they can inhibit the iodination of the tyrosine residues, which inhibits the biosynthesis of the thyroid hormones. But peripherally, the T4 can also be converted to T3, which is going to be blocked by one of the drug PTU, propyl thiouracil. So propyl thiouracil can inhibit the conversion of the T4 to T3 within the peripheral tissues. Now already we have seen that for synthesis of the thyroid hormones, 2 important molecules are required. One is the iodide and second is the tyrosine. This tyrosine can interact with the iodide in presence of the thyroperoxidase enzyme which undergoes the iodination. but this step is a free radical mechanism. Initially, iodide is converted to iodide free radical, and this reaction is mediated by thyroperoxidase enzyme in presence of hydrogen peroxide. And the same enzyme will convert the tyrosine into the tyrosine free radical. You can observe the hydrogen is going to be removed and a tyrosine free radical is going to be produced. Now this tyrosine free radical as well as the iodide free radical can be combined such that they are going to produce the iodinated tyrosine. So this is the monoiodinated tyrosine. In this way they can also prepare the diiodinated tyrosine. So here thyroperoxidase enzyme is important for the iodination of the tyrosine residues, which is blocked by thiourines. So thiourines are going to inhibit the iodination of the tyrosine residues. What are the side effects? These antithyroid agents can produce few of the common side effects like the headache, nausea and vomiting, joint pains. And apart from these common side effects, they can produce the two important side effects. One is the neutropenia and another one is the agranulocytosis. This neutropenia, the decrease in the neutrophil count, can produce few of the symptoms in the patients such as fever, sore throat and chills. Similarly, agranulocytosis can produce the rapid heartbeat and jaundice in the patients. So whenever these two side effects are observed, the antithyroid agents should be carefully given. So that's about the antithyroid agents. Propylthiouracil, methimazole and carbimazole are the antithyroid agents which are belonging to the thiourines. Propylthiouracil is having the uracil structure, whereas carbimazole and methimazole are having the thioimidazole ring system. These drugs are going to inhibit the iodination of the tyrosine residues by inhibition of the thyroperoxidase enzyme within the thyroid follicles. But propylthiouracil can also inhibit the conversion of the T4 to T3 into the peripheral tissues. But still propylthiouracil can produce a hepatotoxicity, so it is somewhat toxic compared with the carbimazole and methimazole. So that's about these antithyroid agents. Hope you have enjoyed this video. If you like this video, please subscribe to our channel, share this video with your friends, post your comments in the comment box. Thank you for watching this video.
So I hope that it was interesting to summarize what we discussed in the previous lecture, and now I will go further for the third topic about radioactive iodine treatment. So now is the time, as I told you, to go in details about radioiodine in the treatment of hyperthyroidism. This is a nuclear medicine option, how to treat, and maybe we have to go for some of the details. Radioactive or radioiodine is an effective treatment as introduction for Graves' hyperthyroidism. It had been the therapy of choice in United States, selected by 60% of thyroid specialists who responded to a survey 2011. Data subsequently have shown that long-term anti-thyroid drug use in safe and an updated analysis using insurance claims data in the US suggests that antithyroid drugs are used as initial therapy for 60% of patients, while only 33% of patients receive radioiodine. Radioiodine is administered orally as sodium iodide This is the dye or the contrast or the nuclear, we can say, material used in solution or a capsule. The radioiodine is rapidly incorporated into thyroid, and its beta emission result in extensive local tissue damage. The net effect is ablation of thyroid function over a period of 6 to 18 weeks. Radioiodine for treatment of hyperthyroidism will be reviewed. The indication, as we mentioned, number one, Graves' disease. The therapeutic approach to Graves' hyperthyroidism consists of both rapid amelioration of symptoms with beta blocker and measures aimed at decreasing thyroid hormone synthesis with the administration of thionamide, radioiodine ablation, or surgery. Because all three treatment modalities are effective, the choice of therapy should involve active discussion between clinician and the patient. Radioiodine had been the most popular treatment for hyperthyroidism in the United States, and worldwide is the same. Toxic adenoma and multinodular goiter also you can use radioactive, depending upon patient preference. Either radioiodine therapy or surgery have been considered in the treatment of choice for this condition. However, a patient can now be managed if preferred or necessary for other reasons with long-term thionamide drugs. Contraindication and precaution for radioiodine. The pregnancy and breastfeeding. Pregnancy and breastfeeding are absolute contraindication to radioiodine therapy. Radioiodine should not be given for 6 to 12 weeks after cessation of breastfeeding. Ensure that radioiodine will not be actively concentrated in breast tissue. Fetal thyroid tissue is present by 10 to 12 weeks and would be destroyed by radioiodine, potentially resulting in cretinism. A pregnancy test should be obtained in women of childbearing age before administration of radioiodine. Rarely, radioiodine given inadvertently to pregnant women. The infant may be normal hyperthyroid due to radioiodine-induced increase in maternal thyroid receptor antibody trap level, which in turn affect fetal thyroid function or hypothyroid. Depending on when during the pregnancy the exposure occurred, each possibility should be considered and appropriate action taken immediately after delivery. In select center with expertise, fetal thyroid function may be assessed in utero by percutaneous umbilical vein sampling after 20 weeks of gestation. However, this procedure is associated with a risk of fetal loss. What about thyroid eye disease? Radioiodine therapy compared with thionamide or surgery is associated with two-fold increase in the development or worsening of thyroid eye disease, which is orbitopathy. The changes are often mild and transient, at least in patients who have mild or no eye disease before therapy, but may be more significant in patients with more severe thyroid disease. Moderate to severe thyroid disease, we consider usually moderate to severe or sight-threatening thyroid eye disease. A contraindication to radioiodine therapy, thionamide or surgery are the options, preferred option for such patient, while not recommend patient who refuse surgery and who have had adverse reaction to thionamide may need to be offered radioiodine therapy with glucocorticoid coverage. Mild active thyroid disease, radioiodine should be used with caution in patients with active mild thyroid eye disease and risk factor for deterioration, including smoking, a high baseline serum concentration of T3, age more than 325 nanogram per deciliter, T3, I mean, sorry, and high trap level, while some experts who do not treat such a patient with radioiodine in one randomized trial, no patient who received the course of oral prednisolone following radioactive iodine developed new or progressive thyroid eye disease, while 15% of patients who did not receive steroid had new or progressive thyroid eye disease. Thus, in patients with mild eye disease but risk factors risk factor progression, concurrent administration of glucocorticoid should be administered to prevent deterioration of eye disease, if no contraindication. Approach to treatment. The following approach to administration radioiodine is consistent with American Thyroid Association guidelines. You have to verify negative pregnancy test because in women of childbearing age, a negative pregnancy test should be confirmed within 48 hours prior to treatment of radioiodine. Pre-treatment with methimazole. The rationale for pre-treatment with methimazole include the following. Number one, there may be a transient exacerbation of hyperthyroidism after radioiodine, which is eliminated by pre-treatment. Methimazole return thyroid function to normal somewhat more rapidly than radioiodine, which can be important for patients who are not tolerating the symptoms of hyperthyroidism, who have comorbidities like heart disease, that make them more vulnerable to effect of hyperthyroidism. In one study, for example, thyroid function was normal at mean of 5.7 weeks after methimazole treatment, while in another study, the mean level of thyroxine T4 was still slightly above normal 7 weeks after radioiodine. This slightly shorter interval to achieve euthyroidism should not be considered a reason for pre-treatment in all patients, since the side effects of potential toxicity from methimazole are significant. Hyperthyroidism is controlled by 12 weeks in 97% of patients taking methimazole, while 10 to 20% of patients receiving single dose of radioactive iodine fail treatment altogether. There is disagreement about benefit of thionamide pre-treatment in patient planning radioactive radioiodine therapy. One of the meta-analysis shows 14 randomized randomized trials. Adjunctive use of thionamide administered in the week before, during, or after radioiodine therapy increase the risk of treatment failure, reduce the risk of hypothyroidism. However, patients who were pre-treated with thionamide had a lower incidence of biochemical and clinical hyperthyroidism for several weeks after radioiodine therapy. Candidate for pre-treatment. Who are the candidate for pre-treatment? Radioiodine can be administered as initial therapy for hyperthyroidism without methimazole pre-treatment in most patients with hyperthyroidism, especially if they are receiving adequate therapy with beta blocker. So if you are controlling your patient with beta blocker, you can go for radioactive iodine with no need for anti-thyroid medication like carbimazole. However, some patients, as we mentioned, who are at risk, like elderly and patients with heart disease, need preparation with methimazole. Methimazole in the following patient as a pre-treatment is recommended: older population, 60 to 65, and other with comorbidities, heart disease, atrial fibrillation, heart failure, and pulmonary hypertension. Patients with severe thyrotoxicosis who are not tolerating the symptoms of hyperthyroidism, especially if on adequate doses of beta blocking drugs, while pre-treatment prolong the period of intensive treatment, it shortens the period during which patients have many hyperthyroid symptoms. Administration in the absence of definitive definitive data to support specific treatment regimen. Usually, a pre-treatment with methimazole for 2 to 6 weeks before radioiodine is the usual approach. Radioiodine can then be administered once serum free T4 and total T3 or free T3 concentration are in the normal range or after symptoms have subsided. The practice to stop methimazole 3 days before and resume it 3 days after radioiodine administration. Methimazole is then can be tapered down, stopped as thyroid function normalize, usually between 4 to 18 weeks following therapy, as determined by thyroid function test after reducing of reduction in the goiter size. Maybe you are using methimazole is the thionamide of choice in all patients receiving treatment prior to radioiodine. Controversy remains as to whether pre-treatment with BTU is more likely to result in a treatment failure than pre-treatment with methimazole. One meta-analysis did not find a difference between the two drugs. However, in two non-randomized trials, compared BTU and methimazole were not included in the meta-analysis. Cure rate after radioiodine in patients received BTU were half that of patients received methimazole. It means using methimazole is preferred. When to stop? Methimazole should be discontinued before radioiodine treatment in order to avoid impairing the efficacy of the radioiodine. So in any patient going for radioactive or radioiodine, you have to stop the medication before administration. Some guidelines tell us 3 days, some guidelines tells us 5 days or 7 days. So according to the guidelines you are following or radiologist is trained on. In a randomized trial that compared stopping or continuing methimazole in 75 patients, radioiodine treatment was successful in 61% of patients in whom the drug was stopped 8 days before radioiodine was administered, as compared with 44% in whom methimazole was not discontinued. Most studies suggest that stopping 2 to 3 days before radioiodine is optimal. As an example, comparison of diagnostic and therapeutic radioiodine kinetics in 316 patients treated with radioiodine who did not receive pre-treatment before therapy, or in whom it had been stopped for 1 to 2 days, found that alternation in uptake curve, and radioiodine half-life were restored to normal 2 days after discontinuation of the thionamide, and that the success rate of treatment was 87%, which is a good percentage. In a study in which thionamide were stopped 2 versus 7 days prior to radioiodine, post-radioiodine free T4 level were higher in 7-day group compared with 2-day group, while 24-hour radioiodine uptake and outcome at 6 months and 1 to 2 years were identical. Another study found no increase in post-radioiodine thyroid hormone concentration when carbimazole was held for only 3 days prior to radioiodine administration. When to restart? Our practice usually to restart methimazole 3 days after radioiodine given to allow better control of thyroid function. Low iodine diet. While the radioiodine uptake can be increased by following a low iodine diet, there is usually not recommended for patients with hyperthyroidism whose uptake are frequently quite high on normal iodine diet, avoiding iodine-containing supplement, including most multivitamin for a week prior to treatment, may increase uptake and allow for lower administration doses of radioiodine. What is the role of glucocorticoid in patients with thyroid eye disease? Radioiodine can cause development or worsening of thyroid eye disease more often than thionamide or surgery. Glucocorticoid given concurrently with radioiodine may prevent worsening of eye disease. So what are the maneuvers or what are the recommendations in such a case? If the patient has mild thyroid eye disease with risk factors, you have to go for prednisolone. Typically, 30 milligram of prednisolone orally can be given starting 1 to 3 days after radioiodine and tapering and discontinuation within 6 to 8 weeks. If the patient has mild thyroid eye disease without risk factor, for patients with active mild thyroid eye disease without risk factor for progression, the need for concurrent administration of glucocorticoid is uncertain. In the absence of major contraindication, we administer glucocorticoid to prevent exacerbation of thyroid eye disease. Some experts do not treat patients with mild thyroid eye disease with radioiodine, but usually the majority we can use coverage of steroid. The dose of and duration of treatment varied according to the in different studies. In two trials, the initial dose of prednisolone 0.4 to 0.5 milligram per kg body weight initiated 2 to 3 days prior to radioiodine, continued for 1 month, and then tapered over 2 months. Also can be used as another regimen. Moderate to severe thyroid eye disease, radioiodine is contraindicated in patients with moderate to severe or sight-threatening thyroid eye disease, and not recommend radioiodine with concomitant administration of glucocorticoid. Smoker without active thyroid eye disease, cigarette smoker who receive radioiodine have a high incidence of new or progressive thyroid eye disease. In cigarette smokers without thyroid eye disease, there is no evidence for or against using prophylactic glucocorticoid to prevent the onset of eye disease. If a smoker with Graves' disease and with no evidence of eye disease are treated with radioiodine, maybe you can go for concurrent glucocorticoid coverage. Glucocorticoid reduce the effective thyroidal half-life of radioiodine by increasing renal plasma iodine clearance. There are no reports that the addition of glucocorticoid reduce the overall effectiveness of radioactive treatment for hyperthyroid state. Other therapy to enhance the efficacy of radioiodine or to reduce the exacerbation of hyperthyroidism that may occur after radioiodine are not recommended. Once therapy has been evaluated as an adjuvant in radioiodine therapy is lithium. Lithium may be prolong the retention of radioiodine within thyroid gland, which could increase the effectiveness of radioiodine therapy. In a retrospective cohort study, a cure rate was slightly higher in patients given lithium. So maybe this is one of the options available to use it. Dosing of radioiodine, most experts advocate radioiodine doses that result in hypothyroidism. You have to avoid extra dose. There is debate, however, whether the dose of radioiodine should be fixed or individualized. based upon the size of thyroid gland and 24-hour radioiodine uptake and turnover. Usually, it is preferred to individualize the radioiodine dose based upon the size of the thyroid gland and 24-hour radioiodine uptake. The dose is calculated based on micro CI pair of thyroid tissue to be delivered. Usually, if you are treating Graves, 10 to 15 millicurie is given to the patient. But again, the accurate dose of radiologist to be calculated by radiologists to prevent hypothyroidism or no treatment of hyperthyroidism. But usually in the clinical practice, 90% of the cases going for hypothyroid. I have some cases going for euthyroid disease status and remain in euthyroid with no treatment after calculation or after administration of the radio active treatment. The low versus high, the primary goal of radioiodine therapy in Graves' disease is to cure the hyperthyroidism by rendering the patient hypothyroid. In the past, it was controversial whether radioiodine should be given in a sufficient dose to induce hypothyroidism or a lower dose in attempt to achieve euthyroid state due to high failure rate associated with lower dose. You see, this is the why we are observing more hypothyroid cases. So due to the high failure rate associated with low dose, patient most expert advocate radioiodine doses that result in hypothyroidism to prevent any failure of the treatment option. Hypothyroidism is less common initially after radioiodine treatment for toxic adenoma and toxic multinodular goiter. Area of focal autonomy take up radioiodine while uptake is limited in adjacent and contralateral thyroid tissue that is suppressed by hyperthyroid state. As a result, radioiodine tend to destroy only the autonomous area and most patients remain euthyroid after radioiodine administration. Patients who develop hypothyroidism usually do so because uptake was not suppressed in the extranuclear tissue or because of the coexistent chronic lymphocytic thyroiditis in up to 5% of patients with toxic multinodular goiter. Radioiodine therapy may evoke the production of TSH receptor stimulating antibody, causing recurrent hyperthyroidism due to Graves' disease several months after treatment. Graves' disease, again, when radioactive is used to treat patient, high dose is preferred. This will cure hyperthyroidism and in most patients may induce hypothyroidism. The ATA or American Thyroid Association guidelines for management of Graves' disease recommend those usually, as I told you, millicurie 10 to 15, sufficient to cause hypothyroidism in most of the cases. And I told you the final calculation and determinant is by the nuclear medicine radiologist doctor. For patients with Graves' disease, the dose of radioiodine is directly related to cure rate and the incidence of hypothyroidism. For example, a trial of 2 fixed doses of radioiodine in 813 patients with hyperthyroidism. Patient treated with higher dose had a higher cure rate and a higher incidence of hypothyroidism. A high dose of radioiodine, for example, 128 to 155 micro CI, cause thyroidism in 90% of patients, but eventually causes hypothyroidism in at least 80%, where 14% have persistent case. Administration of much higher dose is not associated with higher rate of cure, but may be used in patients who are being retreated after one or more treatment failure. In patients with very large goiter, or in patients who have been pre-treated with thionamide, which cause mild radio resistance. Although attempting to lower thyroid function to normal with a low dose of radioiodine may appear desirable, this approach has several disadvantages. In particular, low-dose radioiodine therapy is more likely to result in treatment failure, necessitating another dose after 6 to 24 months. As I told you, there is a chance of failure, so maybe after 6 months at least or more, another dose can be given if patient did not achieve the normal or hypothyroid status. Many patients have chronic subclinical hyperthyroidism with its associated risk of atrial fibrillation and reduced bone density. In toxic adenoma and toxic multinodular goiter, the dose of radioiodine used to treat toxic adenoma or multinodular goiter is higher than needed to treat graves. I have some videos to be shared with you. But before going with this video, I will keep it after the break. Just I would like to mention that some of the available important issue in the
Hey guys, welcome to Endocrine.
We can go with the video, I think. We have, yes, 3 minutes. We have for the video, and then we'll go for the break.
Pharmacology. We are studying thyroid inhibitors, and in this video we will see radioactive iodine or iodine 131. So let's start. It is commonly available as solution which is given orally. After absorption, it goes to thyroid gland. The radioactive iodine accumulates in thyroid follicle same as stable isotope does. Talking about mechanism of action, they emit beta particles which penetrate from 0.5 to 2 millimeters deep and destroys follicular cells from inside. The cells undergo pycnosis, necrosis, and there will be eventual fibrosis of the gland. The process is slow and takes 2 to 3 months till hyperthyroidism is completely controlled. The good thing is there is minimal injury to surrounding tissue. Apart from beta particles, it also emits gamma rays which passes through the tissue and can be measured from external detector. This property is used for diagnostic purpose. Half-life of radioactive iodine is about 8 days. Now let's talk about uses of radioactive iodine. Therapeutically, it is used for hyperthyroidism, for example Graves' disease, toxic nodular goiter, and thyroid cancer. Diagnostically, it is used in low doses to identify some thyroid conditions. Now let's talk about pros and cons of radioactive iodine. First, pros. In contrast to surgery, radioactive iodine can be given on outpatient basis. It is cheaper and it does not involve some of the risks that are associated with surgery like injury to parathyroid gland and recurrent laryngeal nerve. And of course there won't be any scar on your neck, so it is good for cosmetic point of view also. Coming to the cons. There is risk of hypothyroidism as side effect. It takes long for 2 to 3 months till hyperthyroidism is completely controlled, and it is not suitable for children as such children are more likely to develop hypothyroidism later in their life. It should also be avoided in pregnant lady because it may destroy fetal thyroid tissue. So that was the radioactive iodine. Now let's have a quick summary. It is commonly available as solution and is given orally. Mechanism of action includes emission of beta particles which destroy thyroid tissue and gamma rays which is used for diagnostic purpose. Uses are hyperthyroidism like Graves' disease, toxic nodular goiter and thyroid cancer. And also it is used for diagnostic purpose also. The pros are, the therapy is simple, convenient and can be given on outpatient basis. It is cheap and there is no surgery related risks. For example, injury to parathyroid gland and recurrent laryngeal nerve, and there is no scar. The cons are hypothyroidism. It takes 2 to 3 months for effects to develop. It cannot be used in children as there is higher risk of hypothyroidism in later life and in pregnant lady because of destruction of fetal thyroid tissue. So that's it for this video. If you have any doubt or suggestions, please drop it in comments.
Okay, by this I will conclude the this lecture. Please go for break till 6:45 for prayer and have some rest. Inshallah, 6:45 we are back to continue our topics. Welcome again, everybody. Assalamu alaikum wa rahmatullah. It's the time now to resume the third session of second day of our thyroid course. I hope that you are enjoying the course to get benefit of all of these different cases related to thyroid disorders. So before the break, sorry, uh, we reached how to assess the post-treatment precautions. And in 2011, there was one of the published article about the recommendation about the safety for the patient, families, caregivers, and the public after radioiodine therapy. So the recommendations are based upon the clinical experience and available data. However, data on long-term outcomes are limited. The doses of radioiodine administered for the treatment of hyperthyroidism are lower than those used to treat thyroid cancer. The majority of patients with hyperthyroidism can be treated with 131 iodine in the outpatient setting. And example, patient receiving doses up to 55 millicurie for hyperthyroidism can typically be released without exceeding those limits established by the Nuclear Regulatory Commission. So the issue here that if the patient received radioactive material, he or she has to be away from the family because there is a hazard and there is risk. So how to go for the precaution of such a case? This is what we are discussing here. Household contact in the patient family. Patients who receive radioiodine have the potential to expose their home and household contact via saliva, urine, and radiation emitting from their body. So they have to be away from the family. They should be instructed to avoid the following during the restricted period, which depends on the, we can say, amount of radioactive given and the duration that is a restricted period, so will depend according to the clinical scenario. So sharpening, sharing cups or utensils, this is number one. Number two, sleeping in the same bed with another adult, pregnant lady, infant or child, sexual contact, close contact with children and pregnant women. As I told you, this is hazardous and may push material to be distributed to other family members. The period of post-treatment precaution varies according to the dose administered and retained. In USA, close daytime contact with adults should be avoided for approximately 1, 2, and 5 days, and sleeping with another adult should be avoided for approximately 3, 6, 8, and 11 days for doses 10, 15, 20, 30 millicurie. So I will not go for details, but maybe the restriction time up to 1 week, 10 days. So radiologist will calculate it and will give the optimum time as an individualization for each patient according to the dose, according to the status of every patient. What about the future pregnancy? Pregnancy should be delayed 4 to 6 months after radioiodine therapy to ensure that hyperthyroidism is successfully cured and hypothyroidism corrected prior to conception to avoid any material that may pass to the fetus. Some experts suggest delaying pregnancy for a year or more. TRAb level increase after radioiodine and remain elevated for a year, which theoretically would increase the risk of fetal or neonatal hyperthyroidism. However, unintended pregnancy after unintended pregnancies after radioiodine treatment and during this interval should be allowed to proceed to term if it occurs. Congenital anomalies do not appear to be more common in women treated with radioiodine, but as a precaution, avoidance of pregnancy is preferable. The gonadal dose is approximately 3 rad, similar to that for hysterosalpingography for barium enema. What is about the monitoring? After radioiodine, all patients require monitoring for hypothyroidism or persistent hyperthyroidism. Most patients have normalization of thyroid function test within 4 to 10 weeks. So usually we are asking the patient to come again to have new thyroid function test after 6 weeks, for example, to see what is the progression of thyroid function. Hypothyroidism may occur as early as 4 weeks in some patients. Hypothyroidism should be avoided as this is a risk factor for worsening thyroid eye disease. Usually, measurement of free T4, T3, TSH is preferred to be 4 to 6 weeks after radioiodine, and then at 4 to 6 weeks interval thereafter, depending upon the result of prior testing and change in the thyroid size. If the patient remain euthyroid for 6 months, serum TSH should be measured at 6 to 12 months interval for patient lifetime because of ongoing occurrence of the hypothyroidism after radioiodine therapy. If the patient becomes hypothyroid with low free T4, thyroid hormone should be initiated and dose initially adjusted to maintain normal free T4 level. Once euthyroidism is achieved on a stable dose of thyroid hormone replacement, TSH can be measured annually. If the patient has persistent hyperthyroidism, monitoring of thyroid test should be continued at 4 to 6 weeks interval while additional therapy is planned. The principal test used to follow immediate effective treatment of hyperthyroidism is serum free T4. Measurement of serum TSH can be misleading in the early follow-up period because it can remain low for for weeks or even months, even when the patient is biochemically euthyroid or even hypothyroid, with serum free T4 values well within or even below the normal range. When both TSH and free T4 are low, measurement of serum T3 is necessary to distinguish between persistent hyperthyroidism, T3 elevated, and transient central hypothyroidism, T3 normal or low, associated with recovery of hypothalamic pituitary thyroid axis after treatment of hyperthyroidism. Once steady-state conditions are assured, measurement of serum TSH is required to assess the efficacy of the therapy. The percentage of patients with Graves' disease who become hypothyroid within the first year after treatment varies directly with those of radioiodine. Hypothyroidism occurs in approximately 80% of patients receiving high dose of therapy. For example, 160 micro-CI, and 10% of patients receiving low-dose therapy, for example, 80 micro-CI. Hypothyroid that develops within the first year may be transient. In the study of 260 patients who received radioiodine therapy for Graves' hyperthyroidism, for example, 67 developed hypothyroid within the first year after treatment. The hypothyroid was transient in 58%, and however, 70% of those with transient hypothyroidism became permanently hypothyroid in subsequent 2 to 11 years. Most patients who become euthyroid soon after radioiodine therapy develop hypothyroidism at rate of 2 to 3% per year. This occurs because of the late effect of radiation of lymphocytic infiltration and destruction of thyroid tissue, a process similar to chronic lymphocytic Hashimoto thyroiditis. Alternatively, patients who become euthyroid after therapy can develop recurrent hyperthyroidism. This occurs because of regrowth of thyroid remnant under continued stimulation of thyrotropin receptor antibodies in patients with a toxic adenoma or toxic multinodular goiter. Hypothyroidism is less common initially after radioiodine treatment. There is an ongoing risk of developing hypothyroidism. In long study, the prevalence of hypothyroid after radioiodine for multinodular goiter was 64% after 24 weeks. What about the persistent hyperthyroidism? 10 to 20% of patients fail the first radioiodine treatment. In the meta-analysis of more than 4,000 patients with Graves, treatment failure was correlated with male sex administration of radioiodine more than 6 months after diagnosis, prior use of thionamide, 24 radioiodine uptake, 60% and thyroid volume 35.77 in patient with treatment-resistant Graves' disease, persistent hyperthyroidism, takes 6 months following radioiodine. We typically second dose of radioiodine given if the response to the first dose of radioiodine has been minimal, larger goiter persists. Second dose can be administered earlier, for example, 4 months after the initial dose. Patient with rapid thyroid iodine turnover whose 2 to 4 hour radioiodine uptake is higher than 24-hour radioiodine uptake are more likely to have poor response to radioiodine treatment. In one study, the initial cure rate was 28% in patients with high turnover and 66% in patients with normal turnover. Patients with high turnover required 1.5 to 2 times the radioiodine dose to achieve a cure. In addition, patients with large isoechoic gland that have more colloid more likely to be radio-resistant than our hypoechoic gland, which have more densely packed cells. In one study, treatment failure occurred in 22% of patients with either isoechoic and 7% with hypoechoic glands. In one case report, pre-treatment with lithium prolonged radioiodine retention and increased the efficacy of radioiodine therapy in patients with radioiodine-resistant Graves' disease. Because of limited data and potential toxicity of lithium, we usually do not recommend its routine use in patients with radioiodine-resistant Graves' disease. I remind all of you, if you have any question, maybe you can type it down in the chat box, or I mean in the Q&A box better. The next issue here is to go for adverse effect. The adverse effect you know of radioiodine to be quite safe aside from causing hypothyroidism, radiation thyroiditis. There is 1% or lower incidence of radiation thyroiditis, and radiation thyroiditis can cause relatively severe pain. So this is one of the conditions that you have to keep it in your mind as well. Radiation thyroiditis can cause relatively severe thyroid pain that can last 2 to 3 weeks and may be associated with exacerbation of hyperthyroidism unless this hormone store were first depleted with thionamide therapy. In these cases, maybe the use of non-steroidal anti-inflammatory drugs for analgesia can be given, but steroid may require in severe cases also. Rebound hyperthyroidism weeks to months following radioactive iodine therapy, there may be a recurrent, albeit transient hyperthyroidism likely due to radiation-related increase in thyrotropin receptor antibodies. This should be distinguished from radiation-related thyroiditis, which typically develop within 1 to 3 weeks of radio iodine therapy. If rebound hyperthyroidism develop, methimazole should be restarted again and continued until thyroid function normalize. The radioiodine will cause hypothyroidism in most patients, and methimazole can be tapered and stopped after 1 to 2 months. Radioiodine and thyroid eye disease. Most but not all studies of patients with Graves' disease suggest that radioiodine therapy is associated with appearance of exacerbation of thyroid disease, as we mentioned earlier. And we mentioned that this exacerbation of the thyroid eye disease after radioiodine is thought to be due to increase in the level of TRAb following radioiodine treatment that persists for up to a year. In contrast, TRAb level tend to fall after surgery and during thionamide therapy. There have been several randomized trials of different hyperthyroidism treatment in patients with Graves'. For example, in one of the trials, orbitopathy developed or worsened in 33% of patients treated with radioiodine, as compared with 10 to 16% of those treated with methimazole and surgery, respectively. And this study was criticized because all of the patients treated with radioactive become hypothyroid, and treatment with thyroxine was delayed for several months. In another trial, the risk of worsening or new onset orbitopathy was higher with radioiodine than thionamide, in spite of early treatment of hypothyroidism in both groups. The risk was primarily driven by an increase in new eye disease of those randomly assigned to methimazole rather than worsening existing eye disease. A third randomized trial compared treatment with radioiodine alone, radioiodine followed by 3 months course of prednisolone or methimazole for 18 months in about 400 patients with Graves' and slight or no orbitopathy, about 150 patients treated with radioiodine, 23 either developed or had worsening orbitopathy 2 to 6 months after treatment. The change was transient in 15 patients. It persists in other 8 patients. In comparison, none of the 135 patients treated with radioiodine plus prednisolone developed or had worsening of orbitopathy, and 50 of the 75 patients with orbitopathy in this arm of the study improved. In the 148 patients treated with methimazole, 3 with orbitopathy improved, 4 had worsening, and other 141 had no change. These patients were closely followed for development of hypothyroidism and treated immediately. In another study, administration of methimazole after radioiodine therapy did not prevent changes in orbitopathy. What about carcinoma or cancer? The cooperation thyrotoxic therapy follow-up study group followed more than 35,000 patients from 26 centers for cancer mortality after radioiodine therapy. An analysis data through 199 representing a mean follow-up of 21 years revealed no increase in overall cancer mortality. Prolonged follow-up demonstrated a small increase in thyroid cancer risk that was most pronounced in those patients who received radioiodine for toxic nodular goiter and standardized cancer mortality ratio was 2.7% observed. Since the risk of thyroid cancer is known to be slightly increased among patients with nodular goiter, it is possible that at least some of excess thyroid cancer risk is related to undergoing thyroid disease and has no relation with the radioiodine material given. In a 24-year extension of cooperation thyrotoxic therapy follow-up study, about 100 MGY organ exposure was associated with increased risk of breast canceroma and stomach cancer. Another analysis of more than 7,000 patients in the United Kingdom also found a significant increase in the incidence of thyroid cancer and cancer of small bowel. There was a decrease in overall cancer incidence. In a study of 2,700 Finnish patients, there was an increase in incidence rate ratio of cancer risk per 10,000 person years due to cancer of breast, stomach, and kidney. The above study compared cancer risk in hyperthyroidism patients treated with radioiodine to normal population. Gonadal function, radioiodine in the doses used to treat hyperthyroidism usually does not cause infertility or congenital anomalies in the offspring of treated patient. This is one of the questions that maybe you are asked during prescribing radioactive iodine as a treatment. The total dose of tests average 339 micro GY radioiodine administration results in transient reduction in serum testosterone concentration without change in the serum follicle stimulating hormone, improves sperm mortality. Low mortality was seen in 2/3 of hyperthyroidism patients before radioiodine, and no change in sperm concentration or morphology. Peritibial myxedema. Radioiodine may also be associated with onset or worsening of infiltrative dermopathy. The time now to go for one of the videos to see the summary of what we are talking.
Hello, my name is Dr. Margaret McLean, and I'm a nuclear medicine physician in the Department of Nuclear Medicine at Kaiser Permanente Santa Clara Medical Center. This presentation has been created to tell you about nuclear medicine and radioactive iodine treatments that may be needed. Radioactive iodine therapy, or iodine-131 therapy, has been used as a treatment for thyroid cancer or hyperthyroidism since the 1940s. It has an excellent safety record. Because iodine is used by the thyroid gland to make thyroid hormone, we are able to use radioactive iodine, or I-131, as a therapy for well-differentiated thyroid cancers or benign thyroid disease such as hyperthyroidism secondary to Graves' disease or a toxic thyroid nodule. When you meet with your nuclear medicine physician, he or she will explain more about how radioiodine therapy works, the precautions that need to be taken, and next steps. Radioactive iodine is taken by mouth and collects in any remaining thyroid tissue, including thyroid cancer cells that have spread to other places in the body. Since only thyroid tissue takes up iodine, the radioactive iodine treatment destroys thyroid tissue and thyroid cancer cells without harming other tissue. As with any treatments, radioactive iodine may cause side effects. The extent of side effects largely depends on the radioactive iodine treatment dose level. Low-dose therapy may not cause any side effects. Most patients experience at worst relatively mild side effects, but everyone responds differently to treatment. Some patients may experience tenderness and mild swelling of the neck, nausea, dry mouth, or a temporary change in the taste sensation. Women are discouraged from becoming pregnant for a minimum of 6 months following radioactive iodine treatment. Female patients may be asked to take a pregnancy test. Your nuclear medicine physician will discuss these possibilities with you. The best way to manage side effects is to know what to do before they occur, and your care team will work with you to prepare for and resolve any problems. There is some flexibility as to when the radioactive iodine treatment can be done. This will allow you to have treatment when it is most convenient for you. When you come in for your treatment, you will meet with your nuclear medicine physician, who will again review the radiation safety precautions and check that all necessary arrangements have been made at your home and at work. The radioactive iodine therapy dose comes in a capsule pill form, and you will swallow the capsule with a drink of water without touching it to your skin. You may then go home. Your doctor will place a small yellow sticker on your Kaiser card indicating the date of your treatment and the dose of iodine 131 given to you. You will need to keep this sticker attached to your Kaiser card for 3 months, and remember to keep the card with you at all times. If you are not already taking thyroid hormone, your doctor will prescribe the medication to be filled at the local pharmacy. The medication is a synthetic version for thyroid hormone and takes the place of natural thyroid hormone once the thyroid has been removed. For patients who are being treated with radioactive iodine for thyroid cancer, about 1 week later you will return to the nuclear medicine department to have another whole body scan called a post-therapy scan. This is done to determine exactly where the radioactive iodine remains in your body. The scan will serve as a baseline for future comparison. Following treatment with radioactive iodine, your body will contain radioactivity levels that will decrease every day. For this reason, some precautions will be needed for several days after treatment to minimize radiation exposure to those around you. Your nuclear medicine physician will create an individually tailored program for you. The details will depend on the amount of radiation required for your treatment and on your lifestyle, both at home and at work. The written plan will help guide you in taking care of yourself and protecting those around you, especially young children and pregnant women, and you will be given detailed instructions to minimize the time you spend in close contacts with such people. We ask that you avoid areas such as schools, workplace, or places of religious gathering. Your doctor will also discuss with you how long you should remain in your room and sleep in your own bed if you are living with others. If there is no other person in your residence, you can continue with your normal activities of daily living and do not need to restrict yourself to your own room. Only when others are at home with you simultaneously do we request that you remain in your own room as much as possible. The majority of radioactive iodine not taken up for treatment will be excreted in the urine in the first 24 to 48 hours. In order to reduce radiation exposure to your salivary glands and bladder, we encourage you to drink at least 1 glass of water every hour and urinate every 2 hours when you are awake. Please flush the toilet twice after each use with the lid down. If urine is splashed outside of the toilet, clean the spill 3 times with toilet tissue or flushable wipes and dispose down the toilet. Men must sit to urinate. Please discuss with your physician if you're currently using sanitary pads, tampons, and/or diapers. A minimal amount of radioactivity is also excreted in the sweat. At the end of your treatment period, please wash your clothes and linens separate from the rest of the family's laundry. A small amount of radioactivity is excreted in the saliva. Use separate eating utensils and toothbrushes. There is no need to use disposable utensils. Do not cook for others. Please let us know if you will have any travel plans in the next 3 months, as a special letter may be given to you to facilitate security clearance at the airport. Lastly, although we ask that you minimize contact with others, you're not in quarantine. A quick hug and a dry kiss are always fine. Although precautions are needed to avoid unnecessary exposure of radiation to others, radioactive iodine is a safe and effective therapy for treatment of thyroid cancer or hyperthyroidism. We hope this video has given you a better understanding of what to expect in the weeks following your radioactive iodine treatment and the role nuclear medicine will play. We look forward to seeing you in the nuclear medicine department. Thank you.
I think it was a good summary for all of us because how to describe the precautions following radioiodine material was given nicely. Now we'll move further for the next presentation. And the next presentation is the thyroid storm. And inshallah, this topic will be done before the break time. So one of the emergencies in endocrine chapter called thyroid storm. So this is the time to discuss what is the details of this thyroid storm. Try to share it. Yes, I am done here. So what is the thyroid storm? Just a quick scenario here. I have a patient with 22-year-old female, evaluated for tachycardia, fever, agitation, and confusion for the last 3 days following laparoscopic cholecystectomy for acute cholecystitis. The medical history is significant for type 1 diabetes mellitus, which was well controlled on basal bolus insulin, and Graves' disease previously treated with methimazole. Methimazole was discontinued 6 months ago when she was considered to be on remission. Medication are insulin glargine and insulin aspart. On physical examination, temperature was 39, blood pressure is 95/50, pulse rate is tachycardic 132 and irregular, and respiration rate is 24. Patient is confused, appears flushed and diaphoretic. Lead lag is noted. The thyroid gland is diffusely enlarged with an audible brew. Her deep, tender reflexes are brisk. There is a fine tremor of her hand. Examination otherwise is normal, and thyroid function and other work up is pending. So this is a quick scenario for one patient. So presented to ER with these symptoms, and from the scenario, it looks like there is something emergency, which is thyroid storm. This is the usual presentation. Outlines of the lecture including introduction, epidemiology, risk factors, clinical features, scoring system and diagnosis of thyroid storm, treatment, and how to follow up this patient and how to prevent. First of all, thyroid or thyrotoxic storm is an acute life-threatening syndrome. It is due to exacerbation of hyperthyroidism. Thyroid storm may be initial presentation of thyrotoxicosis. You cannot expect maybe patient was misdiagnosed or undiagnosed previously, and it is the first time to be presented as a thyroid storm in your ER. The next issue about the epidemiology. Epidemiology usually or the epidemiology is rare, as we mentioned before, and it is about zero point 0.2 cases in 100,000 population. It is now an infrequent condition because of early diagnosis and treatment of thyrotoxicosis. Mortality rate in the range of 8 to 25% in modern series. So as you see, it is rare, but it is a life-threatening condition. That's why we have to pick up these cases early, definitely. What about the pathophysiology? Pathophysiology of thyrotoxic storm, including increase in the free thyroid hormones, decrease in thyroid hormone binding protein, increase sensitivity of peripheral tissues to thyroid hormone, sympathetic nervous system activation, which enhance the response to catecholamine. What about precipitating factors? Discontinuation of anti-thyroid medication, infection, acute illness, thyroid surgery, and non-thyroid thyroid surgery, thyroid bed trauma, radioiodine therapy, or use of iodinated contrast, pregnancy, particularly during labor and delivery. So all of these are precipitating factors. If the patient, for example, have hyperthyroidism or has hyperthyroidism and went to one of these precipitating factors, you may expect that patient will go for the thyrotoxic crisis, acute illnesses like upper respiratory tract, GIT, gastroenteritis, or whatever, surgeries, whatever it is, or even stress condition. What is the usual clinical features that can be observed uh, that can be observed in the storm? Thermoregulatory system, maybe you observe hyperpyrexia, large insensible fluid loss. Number two, nervous system, confusion, seizure, and coma. Next one, cardiovascular system, accelerated tachycardia, more than 130, atrial dysarrhythmia, heart failure, GI or gastrointestinal tract, maybe you observe nausea, vomiting, diarrhea, hepatic, you may observe hepatic dysfunction, jaundice, psychiatric severe agitation, emotional lability, and neck, maybe you observe goiter. What about the laboratory finding you may expect in these cases? We know that hyperthyroidism usually have low TSH and high free T4. This is the usual primary hyperthyroidism. But again, if the patient has central hyperthyroidism from the pituitary gland, maybe you are seeing high normal TSH and high free T4. So this is the usual laboratory finding. Severity of thyroid hormone is not mandatory in the storm. Leukocytosis or leukopenia can be observed also. Mild hyperglycemia, mild hypercalcemia, and abnormality in the liver function test also may be observed. What about the diagnosis? Clinical ground like severe and life-threatening symptoms can be seen and involve the usual diagnostic measures for thyrotoxicosis and elevation of free T4 and or 3 and suppression of TSH, history of hyperthyroidism, physical finding on an enlarged thyroid or hyperthyroidism. Eye finding is helpful in suggestion of the diagnosis. And there is a scale called Birch-Worth-Coffey point scale to calculate if the patient has hyperthyroidism or thyrotoxic storm or no. It includes, for example, many items. For example, the first item involved in this scale is thermoregulatory dysfunction, measurement of the temperature. So if the temperature, for example, between 37.2 and 37.7, we will give score of 5. If it is, for example, 37.8 till 38.3, we will give score of 10, etc. Down up to 30 points can be given. And the next item is heart rate, beats per minute. If it is more than 140, you will give 25 points. If it is, for example, less than 90, you will give 0 score, and the full list available in front of you. You are calculating the points in this scale. What about the GIT and hepatic dysfunction? Also, if it is absent, no symptoms, you will give 0 score. If it is severe, like unexplained jaundice, you will give 20 points. If it is mild or moderate, we can say, like diarrhea, nausea, vomiting, abdominal pain, maybe you can give 10 points. What about the heart failure symptoms or score? Maybe you can go with the following points. 15 points if the patient with severe symptoms like pulmonary edema. If the patient has crepitation, we label it as a moderate congestive heart failure and we'll give 10 points. Mild pedal edema, you will give 5 points. Atrial fibrillation, if it is absent, 0. If it is present, you will give 10 points. And if there is precipitating event, you will give 10 points in the score. So what does it mean? If you calculate the point, you will go for the interpretation. If the patient has 45 points and more, you are diagnosing thyroid storm. This is number 1. Number 2, if the storm is impending, you may find the score between 25 and 44 points. But if it is less than 25, storm is unlikely. I think this is one of the important scales in the clinical practice. If you like to pick up the cases of thyroid storm or impending thyroid storm. So very important to know how to know the patient if it is, for example, if the patient has thyroid storm or no. Next is how to go with diagnostic criteria for thyroid storm of the Japan Thyroid Association. They have a full table, as you can see here, the diagnostic criteria for thyroid storm of Japan Thyroid Association, maybe a presence of thyrotoxicosis with elevated level of free T3 or free T4. This is number 1 item. Number 2, if the symptoms are present, like CNS manifestation, restlessness, delirium, mental psychosis, coma, etc. Fever more than 38 degrees, tachycardia more than 130, congestive heart failure, according to the symptoms there, GIT, hepatic manifestation, and then go for diagnosis, grade of thyrotoxicosis storm, a combination of features, first combination, alternative combination, requirement for diagnosis, thyrotoxicosis, and at least 1 CNS manifestation and fever, tachycardia, heart failure, or GIT, hepatic manifestation. It looks like this is more complicated. The score, which was seen before, more easily, but just to know about it. And if the patient has thyrotoxicosis and at least 3 combination of fever, tachycardia, congestive heart failure, or GIT, hepatic manifestation, Number three, thyrotoxicosis and combination of two of the following: fever, tachycardia, congestive heart failure, or GI hepatic manifestation. And finally, a patient who met the diagnosis of TS1 except that serum FT4 or 3 level are not available. The question here about a lady of 58-year-old presented to emergency department with confusion. She is found to have raised temperature, tachycardic, hypotensive. After further investigation, she found to be the toxic storm. Given her presentation, what is the first line treatment? So now it's the time to discuss the treatment options available to deal with the thyroid storm. Maybe before going for the correct answer, I want you to participate with us in the chat box down, please. Do you think is it a choice one, adrenaline and hydrocortisone, or choice two, beta blocker and propylthiouracil, and or option three, which is adrenaline and propylthiouracil and hydrocortisone, or option 4, beta blocker, propylthiouracil and hydrocortisone? I will give you a few seconds to think and read it carefully, and please write it down or type it down in the chat box. What do you think? Give you a few seconds more, please. What do you suggest? Any one of you to give your input about this question? Number 4, one of the options. Good. What else? Majority going with the correct answer. Yes, 4 is the correct answer in this clinical scenario. Thanks a lot for your participation. So if we talk about thyroid storm management, thyroid storm is a medical emergency that has to be recognized and treated immediately. Admission to an intensive care unit is required. It is essential to treat precipitating factors like infections immediately with antibiotic or whatever needed. Thionamide drugs, propylthiouracil, methimazole, considered the major lines of treatment. Beta blocker to control symptoms, propranolol, ismolol can be used. Glucocorticoid like hydrocortisone or dexamethasone, essential again in management of thyroid storm. Iodine solutions can be given also. How to treat hyperthermia, paracetamol and cooling, correction of dehydration and nutritional deficiency. You can use fluid, to correct the electrolytes, hypokalemia or whatever. Glucose, vitamins can be given also. What other supportive therapy? As we mentioned before, corticosteroid. If we have any vital signs that is there is instability, vasopressor can be used. congestive heart failure. Also, if the patient presented with heart failure, measurement to treat it should be for treatment should be given. Antibiotic if underlying infection is there. Oxygen therapy also should be given as well. The treatment directed against thyroid gland, as we mentioned, number one item, inhibition of new hormone synthesis, thionamide drugs, propylthiouracil, methimazole, carbimazole. These are the usual options given to inhibit new hormone synthesis. But inhibition of thyroid hormone release, you have to use iodine, potassium iodide, lithium carbonate. Practically, usually in our life, it is difficult, or in our practice, I mean, it is difficult to find this solution like SSKI or iodine, rarely to be used in the clinical practice, but the first item usually is used to inhibit new hormone synthesis, definitely. The treatment directed against peripheral effect of hormone, of thyroid hormone. Usually in the physiology, we know there is inhibition of, or there is conversion, sorry, of T4 to T3 conversion in the peripheral tissue. And to inhibit this conversion, you have to give some medication. And this medication, like, for example, beta blocker, propranolol, and again it is preferred to use propylthiouracil in these cases because it has this opportunity to prevent the conversion of FT4 to T3 in the peripheral tissue. So if you have the option in the treatment of thyrotoxic crisis, propylthiouracil or methimazole, go for BTU because of the inhibition of conversion available in the BTU, in addition of use of propranolol also. Steroid use also help in this item or in this factor, and iodine also helpful. Removal of excess thyroid hormone, maybe like plasmapheresis and cholestyramine. These are the options available for removal of excess thyroid hormone, which is rarely to be used, definitely. But again, some resistant cases, you have to keep it in your mind. What about the anti-thyroid drugs? Propylthiouracil is preferred over methimazole and carbimazole, since BTU also prevent peripheral conversion of T4 to T3. In case of stomach distension, vomiting, or severe heart failure, medication can be given by intravenous or rectal route. This is very important. This is a very important issue in the clinical practice. If patient has to be MPO or cannot take orally, whatever the underlying cause, maybe sometimes you have to go for preparation of rectal route. Some of the pharmacists may use this rectal route preparation of substitutory using methimazole or carbimazole. So keep it in your mind with your pharmacist that preparation of anti-thyroid medication can be used in such a case. Because the iodine could stimulate thyroid hormone synthesis, the iodide should be administered an hour after thiocarbamide has been given. And this is how to treat or summarize how to give thyroid storm treatment. As I told you, propylthiouracil given in doses of 500 to 1000 milligram load, then 250 milligram every 4 hours, block new hormone synthesis, and methimazole 60 to 80, block new hormone synthesis also, but BTU blocks conversion from T4 to T3, propranolol 60 to 80 milligram every 4 hours. Consider invasive monitoring in congestive heart failure patient. Block T4 to T3 conversion in high doses. Iodine saturated solution also can be used. Hydrocortisone like 300 milligram intravenous load, then 100 milligram every 8 hours can be given. The benefit, it prevents conversion T4 to T3 definitely. I have a quick scenario here before we going for break. 57-year-old man with Graves' disease developed agranulocytosis while taking methimazole. Methimazole is stopped until count recover, but he develops nausea and vomiting and present to emergency department. On physical examination, temperature is 39.4, pulse rate is 140 beat per minute and irregular, and crackles are heard. In mid-lung fields, free T4, T3 levels are 3 times above normal. He is admitted to intensive care unit and receive antibiotic, intravenous propranolol, hydrocortisone, and oral potassium iodide therapy. His condition continued to deteriorate and urgent thyroidectomy was planned. The question here, which additional measures could be considered for this patient before thyroidectomy? What do you recommend? A, hemodialysis. B, replacement of propranolol with atenolol. C, plasmapheresis. D, intravenous immunoglobulin therapy. Finally, E, initiation of propylthiouracil. I will give you a few seconds to give your guess. Okay, I started to receive some of your answers. Plasmapheresis, what else? Any other suggestion? It is one of the difficult scenarios, definitely. Plasmapheresis, again, one of the question answers. Plasmapheresis. Majority of you going with plasmapheresis. Yes, majority are correct. Thanks for your participation. Plasmapheresis is the correct answer. Plasmapheresis, urgent thyroid surgery, is a rare situation. Medical therapy is ineffective. Patient develops side effect and contraindication to the available therapy. As a follow-up, a severe thyrotoxic patient improve clinically. Corticosteroid should be gradually tapered until discontinued. Antithyroid treatment should be continued until euthyroid is achieved. Planning for definitive therapy with either radioiodine ablation or surgery. And what about the prevention? Avoiding common precipitants, avoiding abrupt discontinuation of antithyroid drugs. Ensure that patients are euthyroid prior to any surgery or labor of delivery. I have video here, but before going for the video, I like to go for the break. We'll resume, inshallah, at 8 and 10, 8 and 10 minutes. So please go for the break, and 10 minutes will be back to resume the remaining of the lecture or of the sessions. Thanks again. Hope it was interesting for all of you. Thanks and welcome again. I like to share the video with all of you before we proceed to the next presentation. This video to summarize what we talked about in the previous session.
Thyrotoxic crisis, more commonly called thyroid storm, is a severe, acute complication of hyperthyroidism. In hyperthyroidism, there's an excess of thyroid hormone, and in thyroid storm, the symptoms and physiologic effects of having excessive thyroid hormones are suddenly magnified. Normally, the hypothalamus, which is located at the base of the brain, detects low blood levels of thyroid hormones and releases thyrotropin-releasing hormone into the hypophyseal portal system, which is a network of capillaries linking the hypothalamus to the anterior pituitary. The anterior pituitary then releases thyroid-stimulating hormone, also called thyrotropin, or simply TSH. TSH stimulates the thyroid gland, which is a gland located in the neck that looks like two thumbs hooked together in the shape of a V. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into two iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to the circulating plasma proteins. Only a small amount of T3 and T4 will travel unbound in the blood, and these two hormones get picked up by nearly every cell in the body. Once inside the cell, T4 is mostly converted to T3, where it can exert its effect. T3 speeds up the cell's basal metabolic rate. So as an example, the cell might produce more proteins and burn up more energy in the form of sugars and fats. It's as if the cells are in a bit of a frenzy. T3 increases cardiac output, stimulates bone reabsorption, thinning out the bones, and then activates the sympathetic nervous system, the part of the nervous system responsible for our fight or flight response. Thyroid hormone is important, and the occasional increase can be really useful when you need a boost to get through the final rounds of a sporting competition, or when you're trying to stay warm during a snowstorm. Now, hyperthyroidism can happen a few different ways. All of them result in too much thyroid hormone in a hypermetabolic state, where cellular reactions are happening faster than normal. The most common primary cause is Graves' disease, an autoimmune disorder where B cells produce antibodies against several thyroid proteins. These autoantibodies include thyroid-stimulating immunoglobulins, which bind to the TSH receptor on the follicular cells and imitate TSH. Another primary cause is toxic nodular goiter, where one or more follicles starts generating lots of thyroid hormone. In some cases, it's because of a mutated TSH receptor that inappropriately keeps these follicular cells active. Regardless of the cause of hyperthyroidism, occasionally a person can develop thyroid storm, which is when the effect of having excess thyroid hormones is suddenly magnified. The exact reason that this happens is unclear, but there are some proposed mechanisms. The first is that there may be more unbound thyroid hormone in the blood, which is the active form of the hormone. The second is that the level of unbound thyroid hormone may be unchanged, but the tissues might become more sensitive to thyroid hormone. Third, the body might become more sensitive to catecholamines like epinephrine or dopamine, which are part of the sympathetic nervous system. Triggers for thyroid storm include stressors like surgery, trauma, infection, or childbirth. Other triggers are abruptly stopping treatment for hyperthyroidism or taking too much thyroid hormones, which is relevant for individuals that have hypothyroidism. The end result is the same, a state of severe hypermetabolism, so all the effects of the excess thyroid hormones on the body are magnified. The symptoms of thyroid storm are mostly an exaggerated version of the symptoms of hyperthyroidism, which include weight loss despite an increase in appetite because of the higher basal metabolic rate, heat intolerance because the body is producing more heat, and rapid heart rate, sweating, hyperactivity, anxiety, and insomnia because of the effects of thyroid hormones on the sympathetic nervous system. In thyroid storm, heat intolerance turns to fever. Hyperactivity and anxiety turn into agitation, confusion, and can go as far as seizures and coma. Cardiovascular symptoms like tachycardia can turn into cardiac arrhythmias and high output cardiac failure. Thyroid storm can be extremely severe and can cause death if it's not quickly recognized and managed. The diagnosis of thyroid storm is usually based on the severity of symptoms and can be confirmed by tests like an ECG to detect a cardiac arrhythmia. Typically, there isn't much of a difference in thyroid hormone levels between hyperthyroidism and thyroid storm. The biggest difference is how the hormone levels affect the various body systems. Treatment for thyroid storm requires intensive supportive care, with various medications like beta blockers to treat symptoms, thionamides to block thyroid hormone production, as well as iodine preparations, glucocorticoids, and bile acid sequestrants. All of these medications are aimed at reducing the amount of thyroid hormone and its effects on the body. If this approach doesn't work, plasmapheresis can be tried. That's where blood plasma is removed, thyroid hormone can also be removed, and the remaining plasma is returned to the person. Alright, as a quick recap, thyroid storm is an acute, life-threatening complication of hyperthyroidism, where the body becomes very sensitive to the effects of excess thyroid hormone. It can cause symptoms like high fever and severe tachycardia, and because of its high mortality rate, medications like beta blockers and thionamides have to be given rapidly.
Helping current and future clinicians focus, learn, retain, and thrive. Learn more.
Okay, I hope it was a good summary for all of you. It's the time now to go for the next topic. Just a reminder, please, if you have any question, maybe you can type it down in the Q&A box. I intentionally try to collect all the discussion time to be at the end of the day, so we can discuss together all of them. Try to share the last topic. The last topic, as you see here, is the subclinical hyperthyroidism. So the subclinical hyperthyroidism also one of the important issues or topics in the thyroid chapter or thyroid disorder chapters. So please, just I welcome all of you to join us in the Twitter account related to endocrine and diabetes. It is EndoDMOS. This is actually a pure scientific account about endocrinology and diabetes. If you are interested to have more updated knowledge in endocrinology and diabetes, please related to the endocrine and diabetes. So Endo, the MENDOOS, if you are interested to have more updated knowledge or you have interest to have more interaction in the related to endocrine and diabetes, please join us in this Twitter account. I will keep it down in each slide down, just a reminder for all of you. With no further delay, I will start with this quick icebreaker. What do you think this doctor, why he is why patients do not believe he is a real doctor? He is sad. Just give me any suggestion down in the chat box. What do you think? So it's just a quick joke. So able to diagnose the patient properly, good suggestion. But actually, patient don't believe I am real doctor because he has a good handwriting. This is just a reminder for all of us as doctors or healthcare providers, because maybe we are busy in the clinical practice and our handwriting is not good. So maybe handwriting should be in a proper way to give a best care for our patients. Just stimulation for all of you. And now we'll go for outlines of our topic. Subclinical hyperthyroidism, including definition, epidemiology, causes, clinical presentation, laboratory diagnosis, and management. Definition defined biochemically as normal free T4, T3 in the presence of subnormal TSH less than 0.5. The serum overt hyperthyroidism refers to patient with elevated level of free T4, T3 or both, and subnormal TS concentration. Both subclinical and overt hyperthyroidism are biochemical definitions, since hyperthyroidism symptoms are non-specific and may be present in patients with subclinical disease and absent in those with overt disease, especially older adults. What is the epidemiology related to subclinical hyperthyroidism? In general, the prevalence in the community between 0.7 and 12%, more common in areas of world with mild to moderate iodine deficiency, like these overt hyperthyroidism, more common in female smokers and older adults. The etiology, the causes of subclinical hyperthyroidism are the same as overt hyperthyroidism. Like overt hyperthyroidism, subclinical hyperthyroidism can be persistent or transient. So any cause of overt hyperthyroidism may also cause subclinical hyperthyroidism. Excessive thyroid hormone therapy, exogenous subclinical hyperthyroidism is the first one. Second one, autonomous functioning thyroid adenomas and multinodular goiter, which is under the category of endogenous subclinical hyperthyroidism. And finally, Graves' disease, which is autoimmune endogenous subclinical hyperthyroidism. This is a quick reminder how to differentiate between hyperthyroidism causes. As we told you in the beginning of this day, it depends on the radioactive iodine ablation. If it is high or low, we'll go for some differential diagnosis. But if it is no near absent or low, you will go for other differential. The major one is thyroiditis, and in the first category, Graves' disease, toxic adenoma, toxic multinodular goiter. What about thyroiditis? Thyroiditis, usually we have hyperthyroidism phase for about 3 months, then followed by hypothyroid phase for about 3 months, and patient usually going for euthyroid status. But some of the patient may continue to have hypothyroid status lifelong and may need levothyroxine treatment lifelong. hyperthyroidism, if it is associated with antibodies, it is called hashitoxicosis. Patient will have from time to time hyperthyroidism, and due to antibodies, maybe you can give the treatment accordingly. This is again one of the slides that is interesting. Just do nothing. You see the first or the upper part of the slide. It is impossible, but if it is combined together, just do it. Nothing is impossible. Just motivate yourself to reach your goals. Exogenous subclinical hyperthyroidism, about 200 million people worldwide are taking thyroid hormone, all at risk of subclinical hyperthyroidism, whether intentional or unintentional. Many of these patients have hypothyroid, and in them, subclinical hyperthyroidism is not the goal of thyroid hormone therapy. So not all cases of hyperthyroidism subclinical need treatment, and we'll talk about them in a few slides. Subclinical hyperthyroidism is the goal in some patients, for example, in thyroid carcinoma. Why? Because suppression of TSH is needed to prevent any stimulation by TSH to thyroid tissues to recure or to we can say grow the thyroid carcinoma cells. In these patients, the benefit of TSH suppression are thought to overweight the risk of subclinical hyperthyroidism. Endogenous subclinical hyperthyroidism above age 55 years. Maybe you include hyperthyroidism due to multinodular goiter, was subclinical in 57%. Hyperthyroidism due to Graves' disease was subclinical in only 6%. Subclinical hyperthyroidism also occurs in patients with thyroiditis. 63% of clinically euthyroid patients with Graves' ophthalmopathy, euthyroid Graves' disease, 4% of those with Graves' disease in remission. It may also be seen in patients with early Graves' disease prior to onset of more overt hyperthyroidism. What are the clinical manifestations, or what are the clinical signs or findings that may be observed? Usually in subclinical hyperthyroidism, the signs or clinical presentation are the same like overt hyperthyroidism. So most patients with subclinical hyperthyroidism have no clinical manifestation of hyperthyroidism, and those symptoms, if present, may be the same of overt hyperthyroidism. For example, tachycardia, tremor, dyspnea on exertion, weight loss, mild and non-specific usually. So it is similar like the symptoms or clinical manifestation of hyperthyroidism, but in milder form. Some patients have no clinical finding. Many patients have a multinodular goiter with autonomy, toxic nodular goiter, or mild Graves' disease. Most patients are detected through routine screening of thyroid function. Subclinical hyperthyroidism is associated with an increased risk of atrial fibrillation, and primarily in postmenopausal women, a decrease in BMD. I think this is already seen, but by Dr. Hamid, just quick review. You may see some of the signs here in subclinical hyperthyroidism related to Graves' disease, like separation of the nails from the nail bed, which is called onycholysis, and vitiligo, alopecia areata can occur in association because these are autoimmune diseases, and we know Graves' disease is an autoimmune. Usually, autoimmune diseases comes together in what we call it polyglandular syndrome, and tomorrow, inshallah, we have a brief about polyglandular autoimmune syndrome. In the eyes, also, maybe in subclinical hyperthyroidism, we see stare or lid lag occur in patients. They are due to sympathetic overactivity mediated by increased alpha adrenergic receptor in some tissues. Exophthalmos active disease can be, you can see the sclera down. So it means patient has exophthalmos. If you see the sclera down, but sometimes you are seeing the or observing diplopia in patient with patient with Graves' disease. EndoDMOS is one of the Twitter account. Just a quick reminder, EndoDMOS. Please, if you are interested to have more endocrine and diabetes knowledge, please join us in this Twitter account, EndoDMOS. It's a pure scientific account about endocrinology and diabetes. So a Twitter account about diabetes and endocrinology, EndoDMOS, EndoDMOS. We are happy to see all of you to see or to update yourself about diabetes and endocrinology. Again, vertical diplopia. What about diagnosis? The subclinical hyperthyroidism based upon biochemical testing alone is identified or defined as normal free T4 and T3 with low TSH. So this is the crucial laboratory finding. It may occur in the presence or absence of mild symptoms of hyperthyroidism. If TSH less than 0.5, TSH should be repeated with free T4 and T3. Because TSH can be transient, reduced TSH plus free T4 and T3 should be repeated after 1 to 3 months to confirm diagnosis. Once diagnosis of subclinical hyperthyroidism is identified, you have to look for underlying cause. And as I mentioned, all causes of overt hyperthyroidism are applied here in subclinical hyperthyroidism. So differential diagnosis or causes or other causes of the combination of low TSH and normal free T4, T3 should be considered in the differential, including what? Central hypothyroidism, non-thyroidal illness, recovery from hyperthyroidism. Due to a shift in distribution of TSH value, normal people, especially African descent, approximately 3% of healthy Black people have TSH less than 0.4, although it would be unusual for TSH to be less than 0.1. Identifying the cause, measurement of thyrotropion receptor antibodies called TSI and TBII or TRAP, positive confirmed Graves, as we mentioned before, negative not distinguished among the others, but TRAP may be not elevated in patients with mild Graves also. You have to keep it in your mind. Determination of the radioactive iodine ablation. As I told you before, it is a crucial test to go for thyroid uptake scan in any patient with hyperthyroidism, whether it is overt or subclinical. Can be initial test or a secondary test in patient with negative TRAP if the scan show one or more focal areas of increased uptake, differential including toxic adenoma or toxic multinodular goiter. High uptake is suggestive of Graves, low or no uptake, the etiology may be thyroiditis. And I showed you the images earlier in this today. This is a quick MCQ for you. I want your participation. Which radiological test this patient is undergoing? A, CT scan of the abdomen. What do you think? B, CT neck. C, bone mineral density. D, MRI pelvis. So please put your input down in the chat box. I will give you a few seconds. Read it again and type your answer down, please. So let's see your answers. A, majority going with CT scan abdomen. Strange. C, I have one here with C or two with C. Good. So actually it is C. It is bone mineral density. Usually CT scan of the abdomen, it is closed. Some machines are open, but it will not come with this photo. This is bone mineral density or DEXA scan to know the bone density in this elderly female to know if the patient has osteoporosis or no. So it is bone densitometer. So thyroid ultrasound to look for discrete nodules is also be used in postmenopausal female or other patient at risk of osteoporosis. Bone densitometer may be useful in making a decision to treat subclinical hyperthyroidism or to monitor. This is again stimulating slide. Never stop working on yourself. You have to improve yourself. You have to work on yourself to reach your goal. I have a question here for all of you. This thyroid uptake scan is suggestive which underlying cause of hyperthyroidism? Is it toxic adenoma, thyroiditis, toxic multinodular goiter, Graves' disease? I'll give you a few seconds. If you were concentrating with me in the beginning of this or today lectures, it means you can answer this question. I'll give you a few seconds. Let's review your answers. D, A, D, A. Actually, the correct answer is D, because there is a diffuse high uptake in all gland, both sides. It means diffuse goiter. It means hyperfunctioning whole gland. It means Graves' disease. Just a quick review. I showed you earlier in this today the slide. Normal, this is the uptake for the thyroid gland, and Graves' disease, high uptake in all the gland, both sides, including the isthmus. Toxic multinodular goiter, high uptake in both sides, including multiple nodules in both sides, hyperfunctioning, high uptake. And finally, toxic adenoma, one adenoma either in the left or in the right side, for example, with hyperfunctioning high uptake. So if we have low uptake also, it means thyroiditis is the diagnosis of your patient. Potential consequences of subclinical hyperthyroidism. The skeleton and cardiovascular system are the major target tissue adversely affected by subclinical hyperthyroidism, although abnormalities in other systems have been reported. Clinical manifestation of subclinical hyperthyroidism quickly review in bone diseases, including decreased bone density, especially in postmenopausal women, increased fracture risk, biochemical markers of increased bone resorption, heart disease, increased incidence of atrial fibrillation, increased heart rate and incidence of atrial premature beats, increased cardiac contractility, increased left ventricular mass index, laboratory abnormalities. decrease in serum total and LDL cholesterol concentration, increase serum concentration of hepatic enzymes, increase serum concentration of SHBG globulin. Progression to overthyroidism. Yes, progression to overthyroidism appear to be related of the degree of subclinical hyperthyroidism and underlying disease. The lower TSH, the more chance of complication. Spontaneous recovery also being described in patients with subclinical hyperthyroidism. Patients with the management usually patient on T4 for treatment of hypothyroidism, dose adjusted to maintain normal serum TSH concentration. So in some cases, the cause may be iatrogenic from the thyroxine, for example, and in these cases, the treatment option available is to adjust the dose of thyroxine. If you adjust the dose of thyroxine, patient will go for normal TSH and we are treating subclinical hyperthyroidism. Patient on suppressive T4 therapy in patient, for example, under treatment of thyroid carcinoma, patient with thyroid cancer, subclinical hyperthyroidism is the goal of thyroid hormone therapy. In these patients, benefit of TSH suppression are thought to outweigh the risk of subclinical hyperthyroidism because, as I mentioned before, I'm repeating myself because it is very important point. TSH should be suppressed in thyroid carcinoma cases. Why? To prevent any stimulation from TSH to remnant thyroid tissue to prevent any growth or possibility of growth of cancerous cells available. Endogenous subclinical hyperthyroidism, patient at risk of complication, patient at low risk of complication. You have to classify your patient under these T2 categories, and then you can give the proper management accordingly. Patient at high risk of complication, who are these? Who are those patients? In patient at high risk for skeletal or cardiac complication, for example, age more than 65 years of age, patient with or at risk of cardiovascular disease, or postmenopause or at risk of osteoporosis. So these are the patients who are at high risk. And also TSH less than 0.1. In these patients, usually you have to treat the underlying cause. So our approach depends on two issues. The first issue, presence of risk factors, and the second issue, the value of TSH. So if the TSH value less than 0.1 and there are risk factors mentioned here, age, presence of cardiovascular, postmenopausal, osteoporosis, treat underlying cause with the treatment options available, like, for example, radioactive iodine or treatment with oral drugs, anti-thyroid drugs. But the other category, if TSH is little bit, we can say not too much suppressed between 0.1 and 0.5. Treat, especially if there is underlying cardiovascular disease. If the bone density is low, it means there is osteoporosis, or if the patient has hyperthyroid symptoms. So again, if the patient is symptomatic, patient has osteoporosis, patient is a cardiovascular disease, in this range, treat. But if the patient in this range has no these issues, don't treat. The other entity here is you have to treat if the scan show one or more focal area of high uptake. Since subclinical hyperthyroidism due to an autonomous nodule is likely to progress to overt hyperthyroidism, yes, you have to treat. Observation, one of the options, if patient is asymptomatic, especially in the absence of autonomous nodule on the thyroid scan, in the patient with normal bone density is normal, patient who are taking osteoporosis drugs, to reduce bone turnover, and in patients who are taking beta-adrenergic blocking drugs for other reasons. In observed patient, measure TSH free T4, T3 every 6 months and obtain bone density measurement every 2 years. So it's not the approach is not leaving the patient. You may monitor them, looking for any symptoms, any deterioration in the thyroid function test. So one of the options available in this category. Let's go now for the second category, which are the patients at low risk of complications. So patient with patients who are at low risk of complications. In patients at low risk of complication of hyperthyroidism, including age less than 65, premenopause, you have to look for the following. Number one, if TSH persistently less than 0.1, treat underlying cause, especially if the patient has symptoms and have patient thyroid radioiodine scan shows one or more focal area of increased uptake. Number two, observation in asymptomatic patient, especially in the absence of an autonomous nodule on thyroid scan and in patient taking osteoporosis drug or beta blockers agents. If TSH between 0.1 to 0.5, observation alone is appropriate. Measurement of TSH 3 T4 T3 every 6 months is advisable. Again, patient at low risk, not all of them should be treated. It depends on the TSH level, presence of the symptoms or absence of the symptoms. Maybe sometimes you can treat with a symptomatic treatment, no need for antithyroid drug. So this is the approach of patient with low risk. This algorithm is summarizing what I talked about or what I mentioned, indication for treatment of endogenous subclinical hyperthyroidism in non-pregnant adult. Does the patient have any of the following? For example, age less than 65, cardiovascular disease, osteoporosis, yes or no? If yes, look for TSH less than 0.1, treat between 0.1 to lower limit of normal. Look for osteoporosis, cardiovascular disease presence, yes or no. If yes, reasonable option include treatment of the underlying cause, but if it is no, does the patient have either symptoms or no, an autonomous nodule seen in thyroid uptake? If yes, again, maybe you can treat, but if no, go for observation. The other entity in the left, in the right side, if no risk factors available and TSH less than 0.1, look for the symptoms and nodule functioning in the thyroid scan. If no, go for observation, but if it is positive, you have to treat or it is preferred to treat. But if the patient has no risk factors, TSH less than 0.1, the best option in this category is to go for observation. The treatment options are the same for those for overt hyperthyroidism, including beta blocker are useful to control the symptoms like palpitation and tremor, Graves' disease or nodular thyroid disease with autonomy, thionamide, carbimazole, methimazole, propylthiouracil, radioiodine, or surgery are the options available in this category. Thyroiditis, which is inflammation transient, require no treatment since dysfunction is rarely severe and is transient. TFT or thyroid function test should be monitored initially every 4 to 8 weeks until normalization. Symptomatic patient may benefit from beta blocker. Thionamide, this is a quick MCQ for you. thionamide may cause, what do you think? A, leukopenia, B, leukocytosis, C, renal failure. I'm waiting your response in the chat box. I'll give you a few seconds. If you were concentrating with me, you will get the answer definitely. So what do you think? The association of thionamide with leukocytosis, leukopenia, or renal failure? Let's see your answers. Leukopenia, leukopenia, leukopenia. Yes, all of you going with leukopenia. Excellent. Yes, it is leukopenia. In summary, I will summarize this topic, and then we'll receive your questions or to see the questions in the chat box. And I told you before that I collected discussion time between each lecture and the other to be here. So if you have any interesting point, please, we can discuss. We have time. Most patient, in summary, most patients with subclinical hyperthyroidism have no clinical manifestation of hyperthyroidism, and those symptoms that are present like tachycardia, tremor, dyspnea, and exertion, weight loss are mild and non-specific. Diagnosis of subclinical hyperthyroidism is based upon biochemical testing alone. Causes are the same of overt hyperthyroidism. Treatment depend on individualization. So this is the key point. Individualization. Not all patients with subclinical hyperthyroidism need treatment. Looking for risk factors, looking for TSH values, looking for some other comorbidities availability. All these are the measures of how to deal with the treatment of subclinical hyperthyroidism. Just a quick reminder for all of you, kind follow our follow of the Twitter account related to diabetes and endocrine. It's a pure scientific one. EndoDMOS, if you are interested to have more knowledge, more updated data about endocrinology and diabetes, please follow us. EndoDMOS, ENDODMOS. I think already now is the time to receive your questions. I will review the Q&A box. It's already 9 p.m. So if you have, we'll review the chat, the books for answering your questions. 2-3 minutes to give you chance. Okay, I think one of the questions I answered already. It is essential to go for FT4 and FT3 with low TSH. Yes, because there is variant called T3 toxicosis. FT4 will be normal and only FT3 will be high with low TSH. So yes, the answer is yes. By this, I have to thank your presence, the audience. I have to thank the organizers to give me this opportunity to share with you a quick review about thyroid diseases. And I hope that I delivered the message properly and you enjoyed today, second day, and the first day yesterday. Hope to see you tomorrow, inshallah, in the last day. And finally, I have to conclude. نستودعكم الله. السلام عليكم ورحمة الله وبركاته. تصبحون على خير.